to KONGU PEDICON 2025. This year marks the 49th Annual State Conference of the Indian Academy of Pediatrics, Tamil Nadu State Chapter, and we are so proud to be hosting you right here at the iconic CODISSA Trade Fair Complex in Coimbatore, fondly called the Manchester of South India. Here, in this vibrant city where tradition meets modernity, we promise you an experience you will not forget. Over the next few days, you will see first ever features we've specially curated for you. From an exhibition of cutting edge innovations in pediatric medicine to immersive cultural evenings and social events where you can relax, network, and enjoy the legendary hospitality Coimbatore is known for. Because KONGU PEDICON 2025 is more than a conference. It is a celebration of learning, of collaboration, of camaraderie, and of our shared commitment to improving child health. So let's come together to grow, connect, and inspire one another. Let's make these days truly unforgettable. Once again, welcome to KONGU PEDICON 2025.
Wish you all a very happy Independence Day. So let's all rise up for the national anthem. May I request all the faculty and the delegates to kindly rise up for the national anthem, please. So without much further ado, we shall start the sessions. So may I now call upon Dr. Neelakandan sir as the chairperson for the first session. Sir is former professor of pediatrics at Coimbatore Medical College and PhD Institute of Medical Sciences and Research. Sir is a great academician and clinician par excellence with over 40 years of experience. Welcome you, sir, onto the dais.
May I now call upon Dr. M. Singaravelu sir, who will be presenting on burnout and pediatric training, strategies for prevention.
Good morning to all the delegates. It's a pleasure as one among you to begin the first session of our state conference 49th PEDICON. The session begins with the first speaker, Professor M. Singaravelu, who is going to talk on preventive strategies for preventing stress among students during their postgraduate programs. Professor Singaravelu, a well-known academician who has decades of experience in various medical colleges, currently is working as Professor of Pediatrics at Vinayaka Mission, Karaikal. And to his credit, he has a lot of presentations in various conferences and received a long list of awards for various categories, being interested in community pediatrics, PALS, NALS, and breastfeeding practices. I invite him to give his lecture on this subject, please.
Good morning to all. Thank you, Chairperson sir, for your nice introduction. At the outset, I wish you all a very, very happy 79th Independence Day, which coincides our historic KONGU PEDICON, that is the 49th, our annual conference. Yes, sir. Yeah, it is our tradition. Whenever the first session starts, our person, none other than Professor Rajendran, our President IAP-TNSC 2025. Give a big clap. It is not for the conference alone. He made a history, his team, that in the same place where we are going to have our National Pedicon, IAP 2027, after the dream of 21 years in Tamil Nadu. He made it happen. His team made it happen. It is a big historic. So this conference is going to be a teaser conference. That's what we always say. It is a trial which we are going to. I am very happy that Ramasamy sir is here to witness all these things and guide us. Thank you, sir. Thank you. I need not mention each and every one of you. If we mention Ramasamy sir, it means that whole credit of IAP-TNSC is there. Thank you, sir. Over to
Good morning to everybody. Respected seniors and friends and delegates, on behalf of IAP-TNSC and the organizing team of KONGU PEDICON, I welcome one and all. And it's a great pleasure to inaugurate this today's session and as well as this conference. And hope that we are having another 3 days and you can enjoy this atmosphere. Yes, Dr. Singarvel sir correctly said this venue will be for National Pedicon. And I hope that we learn a lot of things from this conference. And again, I thank one and all for this opportunity. Thank you. Dr. Narmada.
Good morning all. A very warm welcome to the 49th Conference of Indian Academy of Tamil Nadu State Chapter. I am indeed very grateful that I have been the secretary and it's happening in my hometown. So welcome you all for the conference and very happy Independence Day to you. Thank you.
Good morning all. Happy Independence Day. Hope all of you enjoy the academic feast and in this unique hall. And I wish you all and welcome to the KONGU Mandalam. Thank you very much.
So wishing you all a happy Independence Day. As an organizing chairman, I am indeed a great pleasure in welcoming you all to this 49th State Pedicon of IAP-TNSC. Thank you.
Good morning everyone. I wish you all happy Independence Day. And we have done everything to deliver our best scientific program. I hope it will reach the target. Thank you.
Good morning, Dr. Thirumungan, Academic Coordinator. And we are really happy on behalf of IAP-TNSC and KONGU team to welcome all of you. The KONGU Pedicon is unique in a lot of ways. We have got the maximum ever number of speakers and faculty over here till now, ever in our in any state conference, more than nearly 200 speakers, number one. Number two, for the first time ever, we are going to have 3 concurrent halls. And there are a lot of news in this conference. So I think we request each and every faculty and attendees to just go around and make sure that and have a very pleasant stay in Coimbatore. Thank you very much.
So it's a real blessing as I am being the opening batsman of this historic event. I was telling also the Triple B sir, always he used to do in those days. Okay, without wasting much time. This topic, I was not knowing. Just one day, last week only, always Aswath, he's a man of the great scientific person. He sent a mail. I actually, 4 or 5 days back only, I saw a mail that I am a speaker that what is burnout in pediatric training strategies and prevention. I think he selected me in the way that I was the fittest person to talk about you. That's why he has given. Okay, why? What is this? Really, this topic is very relevant. But unfortunately, for whom it is needed, people should be here to know about it. People who have succeeded by knowing the principle are sitting here. Like our Ramasamy sir, PRC sir, Triple B sir, and so many Krishnasamy, Jalil, so many people are there. If I start mentioning our Nemi and if Nandini, everybody, if I start mentioning. So these people who have succeeded, but lot of people has to succeed by knowing this, otherwise lot of things will happen. Because what is burnout? It is not physically only. It includes emotional, mental exhaustion, all collectively called. The one denominator for everything is chronic stress. It may be profession, personal, family, whatever may be. But what the topic is regarding the pediatric training. So, I need not talk about family and other things, but it is very common in healthcare, that too in specialities like pediatrics, OG, and so on. That is why, if you see the trend, youngsters selecting, because in those days, when our days, toppers only will take pediatrics. Now, toppers are not preferring pediatrics. They are going for dermatology, radiology, which is those days not heard of, not considered as. Why? The reason behind is, the main reason is burnout. What? That is the thing. So, once if you are in stress, it affects your mood, energy, and performance. Why we are more in pediatric? Because always we are facing emergencies. It is not only the child which matters, not only the family matters, the entire community matters. So, we are in a very stressful situation around us. When a child comes with one attack of fits, it may be a simple febrile fits, but the whole family will create a situation. We are knowingly, unknowingly under stress because of this. Of course, now Google parents everywhere. So, we have to update, and we should be up to the academic things. Otherwise, because some busy people, they don't have time to breathe, take food and all that, because they feel. And most of the places, I have been in teaching side for nearly more than 35 years. And as a GP, as a consultant, and overthink more than 45 years. So, my journey is in all those seats. So, I can tell even because of our long working hours, we are not sleeping properly, and we are not taking care of ourselves. And we always in a emotional stress and no control over duty days. And people, PRCs and others who are in a long time in a government service like me, they know our duty sometime will be 48 hours. In rotation duty comes, we will be doing Sunday and again Monday our duty. Saturday our duty, Sunday rotation. 48 hours, continuously. As a postgraduate, no, nothing. Now, this has resulted where now the youngsters are giving adequate rest and all that. Now, no 24 hours duty for postgraduate, NMC also given. But we all crossed that, missing so much of personal life. And what are the risk factors apart from academics? Many times we may not get support from everywhere, and senior bureaucrats may not support, our colleagues sometimes may not support because of jealous and other things, so many things, and night shifts, and so many working conditions also may not be there. And ultimately, we are not in younger age, not bothering about work-life balance. Of course, now it has come out very well in those days, because as just now I was talking to Ramsamy sir, was telling, prime people who are in the prime career of their peak career, they left out of the profession in the age of 45, 50. They retired, all because of burnout. It is called a burnout syndrome, sir was telling. I was happy that the topic was given here. So, we youngsters should not go to that stage by looking our seniors as example. So, what are the warning signs? It is not the end. You should be able to know when you feel tired even after your sleep, when you are irritable always, frustrated, and when you are forgetting things often, avoiding your own colleagues and other things, not feeling yourself. So these all, if you are there in the, not that the terminal stage of burnout, these are all the warning signs which will end up on your poor performance. Your attention will decrease, your empathy towards patient will decrease, and poor communication. And you may not examine the patient properly, you may not give proper treatment, and everything you will try to make more errors, and ultimately your health suffers, your patients also will suffer, which you have to. So, it is not burnout is only on mental health. Of course, the ultimate end is mental health. That because you may end up in anxiety, depression, your confidence level comes down. See, when you are active and whatever risk cases comes, you will be able to manage. When you are not in that phase, when you are in depressed, when your confidence level drop, then even your best performance may not happen at that point of time. You may be not having the confidence to face. These are the situations which you have to take care of. So, it should be prevented. Can it be prevented? Yes, but it should be prevented to have a long, lengthy in a career, because your rich experience should not lose by burning ourselves without taking care of ourselves. That is why you have to plan right strategies. You should know your limitation, your awareness, but you should try to take people around. That's called institutional support, always teamwork. That is the reason now many of the single person owned hospitals are getting close. More people are moving towards corporates. The reason began they are not able to meet out the stress, not only of the patient, about the community, about so many things in a running hospital and doing apart from their practice. So always you try to balance, promote your work-life balance. You should take regular breaks. Of course, youngsters are nowadays doing very well by seeing IT people. IT people, they don't work on Saturday, Sunday. They work only 5 days, that too limited. We doctors, even in Deepavali, nothing, we don't celebrate. Our children will be longing for us. But emergency case will come. Of course, those days we consider as a noble profession. And we were needing money both way. But of course, it's still a noble profession. But தனக்கு மிஞ்சிதான் தான தர்மம்ங்கிற ஒரு சிச்சுவேஷனை நம்ம we have to. It is not for தான தர்மம். We have to do a better things unless சவுற்றை வச்சு தான் சித்திரம் வரைய முடியும். நம்ம நல்லா இருந்தால் நம்ம நல்லா பண்ண முடியும். So I too learned in the age of 50s only, I agree. Because till 50 I was not taking care of my health also. Now I am taking it. So I may be an example where burnt out, almost I note the early warning signs. And I came out of it. Now I am able to do things in a better way because I could realize that what I am doing is wrong. That what I achieved is enough. That is how we have to come out. So take regular breaks, set your limits, sleep well, and you can't pour in empty. Unless you are full, you cannot deliver things which you have to. So nowadays that is why group practices. Don't be jealous. Try to have a group practices. When I am not there, my other person should take her. Oh, no, my case will go to other. I will lose. I have to go and see the patient. That attitude should. That world will revolve. Even if you are not there, things will go on. We are not the destiny. We are not the end of it. That part, we have to take care of ourselves. So that is a way. So limit duty hours, provide mental health access, fair rotations and all that. Leadership, develop a leadership. Engage others, encourage juniors. Unless once we reach a stage, we let others grow, then attitudes will get. How the mentorship matters. You should get a proper mentor. You should take a person. So here seniors are there. How many mentors are he has created? When we go to Mechanic, people talk about Ramasamy sir and his followers all sitting here. So I am happy that since sir is there, all is reasonably full. Because his followers are here to listen his lecture. So my lecture also gets some importance. Thank you, sir. Learn from their journey. Build a safe learning environment. Always think that you are not alone. And you are not the end of it. That is more important. And peer support is very, very important. So you create safe spaces, vent after hard days, share with your feelings, whatever may be, whether it is personal, profession, whatever may be. Support each other. You help others. Definitely people will help us. And of course, how you can enjoy whatever the situation. துன்பமரும் வேலையிலே சிரிங்க என்று சொல்லுவச்சார் வள்ளுவரும் சரிங்க. So whatever it is, you enjoy that situation. The teamwork relieves most of your stress. What is resilience training? This is what, even of course, NMC also stresses. I am in teaching side. Whatever is first year student joins, we immediately create a mentor-mentee relationship. So we create a mentor for everyone. Every 5 students was given one staff advisor. These is a mentor. That is how we are building up. So how to learn stress management, how practices mindfulness, and try to divert your habits and all that. Stay positive during even encouragement. Small win. You satisfy yourself. Whatever I achieved, I am happy. I want to achieve more. If oh no, I want that, I am not able to reach that. Forgetting what I am today. I should be happy with that. What I am going to be tomorrow, I want to become a prime minister, I want to become a governor. Not my aim. Whatever you do, that will make you very happy. So, recognition, appreciate small efforts, acknowledge hard works, constructive feedback, that only make you grow very well. Every celebration you should win. That is a motivation. You should motivate, feeling, sense. First we have our own morale should be boosted. Not comparing. Never compare others. You do whatever you are doing. You are born to achieve your own. Not to think of. These smaller things will make us feel very happy. And it will bring out our energy level full. And we can make more things. So encourage autonomy. We as teachers should encourage our juniors. So unless they should be given, without making mistakes, nobody cannot be. Everybody has to make a mistake. Only thing we have to supervise, allow them, let them do things, let them speak in the rounds, involve them in planning. Trust builds confidence. So that once he gets, then he will gain the confidence, he will be able to better. So empowered doctors will do better. So you should. So the practical tips for trainers which I want to give. Always keep a gratitude. Respect seniors. And always seniority should be respected. If you do that, tomorrow when we become seniors, we will be respected. That is the policy which I followed. I am getting it. What I paid is now reaping. I am getting my juniors, my students, wherever go, the way they respond, respect. It is a thing. So this is a very practical thing which I want to share with you. Don't skip meals, of course, sleep. Say no when it is. Don't forget to say, when you are busy, when you ask your juniors to take over. Don't think that you must see everything, I am the boss. That attitude it will make you at one day to suffer. At that time, nobody will be there to help you. Whenever it is needed, don't hesitate to ask for help. So the institutions also will take a role in preventing this burnout by proper training, giving adequate support, regular check for trainees, flexible and duty planning. Previously, you all serious might be. So the whims and fancies of our bureaucrats, how we all could have suffered. But now, of course, things are changing. But still, people should know how we have to come out. Celebrate wellness, not just so create a positive. Wherever you are working, you create a positive culture. If everything is positive, even in a worse situation, let it be in a family, wherever, because we may have pressure in our family. When you come to working spots, if it affects that, our performance will go down. So it is not exclusive for our the academic only or the patient only. Even in our personal life, everybody will have their own ups and downs in their life. We have to. So in summary, burnout, it is not a myth, it is a real one. But it is a preventable one. It has to be taken both in a personal, you have to change ourselves, and also we have to change the system also, where we work. If the system is not suitable to us, you should not hesitate to come out. Not roaming around that and keeping everything and brooding and wasting. Small habits will protect your health, support each other. You are valuable. That is more important even on tough days. So it is a very short lecture. At the end, see, work-life balance is the most important thing. Our health is our priority. Whatever we earn, either in terms of power, money, whatever it is, svatrai vaithudan sitru. If our health is affected, nobody. I have seen many of our own colleagues, how we lost them in the prime age of their life because of their not taking care of that, seeing patient, money, and all that. We have to let us protect our passion and purpose. And you have to take care of yourself. Unless we are healthy, we cannot make the patients healthy. So with this, I end up my talk. we all should work and take the passion of our seniors, which will help us, because that is why we always say, no, role model, role model, role model. You should have role models in beginning of your career. That role model will make you how they are even at that particular age. See, while I am entering, Ramasamy sir, why I am repeatedly mentioning, no, see, we always admire as a student, when I was a DCH student in 80s, his lectures will be the prime focus. So like that, Triple V sir, Ramachandran sir, so many people are here, and if I start mentioning, my time is already out. So with this, it is a very wonderful beginning of the conference where we all should be happy, do good human service, good service to patient. We should not burn out by ourselves, letting our rich experience, rich knowledge should go waste in the peak and prime of age. It is not about money alone. It is about the community as a whole, about your family, and so many things. With this, I once again thank the organizing team and my good friend Aswath, the scientific chairperson, for giving me this wonderful opportunity, and all the listeners and all my seniors. I dedicate this by yet another happy Independence Day wishes. Thank you all for giving me so much.
Thank you, sir, for your nice presentation, insisting upon the practical difficulties being nicely explained. I'd like to invite Professor P. Ramachandran sir to deliver his lecture, please.
Very good morning to all the people here, respected seniors, my dear colleagues. My deep appreciation, gratitude, and respect to the organizing team of KONGU PEDICON for this wonderful event. Is it changing? Yeah. Bringing greetings on the Independence Day. The topic which I am taking is translating evidence, 5 landmark pediatric papers from 2025. How does one go about selecting what are the good papers, how important they are? Actually, I prepared one, helped preparing for Professor Panna Chaudhary way back when he presented 10 landmark papers which changed my practice. That was a bit easier because there are so many papers, so many things. Like Scorpion Singh, Dr. Bhavaskar's papers I could include. So, but this is, in 2025 I am supposed to pick. And I am not the one who has got access to all the scientific journals, everything. So how do I go about? I tried my best to browse through whatever the scientific evidence which was available. And the landmark papers are defined which have an impact on your change of practice, whether they are going to change the way you are practicing or you learn some new things about the way you are practicing. It adds strength to your practice, your way of thinking. Or some evidence which was missing, it gives you those evidences. For example, you have been using drugs like some, let us say, probiotics. There are some papers which are coming which strengthen your rational use of probiotic. You feel happy. Okay, so that's what we are looking at when we are looking at the landmark papers. But when I Googled for landmark papers, the top one, which was quoted in multiple papers like Nature, New England Journal of Medicine, was this paper, which was the mitochondrial donation which was given to the embryo which was affected by mitochondrial disease. The mother is the mitochondrial carrier disease. The father is normal. They identify the zygote which has got this problem, and this zygote is put into another healthy woman ovum, and lo and behold, they have come out babies without this mitochondrial disease problem. So out of the 22 babies which are done, they were successful in about 8 babies. This was considered as a landmark study. But definitely, it is great science, but it is possible for us. Except in UK, no other country this kind of genetic transfer, mitochondrial transfer is now legally permitted. Including US, it is not legally permitted. So that lot of ethical, scientific, and social issues were there. Though this is quoted as a landmark paper, it is good for our knowledge. But what about our context? So I looked at the Indian context for our practice. What are the papers which are likely to be useful? And especially to pediatrics and clinical orientation, because there are some papers which are purely academic, some basic science like biochemistry or molecular genetics alone, not having a clinical bearing. And you should have a developing country perspective, whether it is possible for countries like ours to practice this. And lastly, it is like some of the actors, burnt out actors giving the Thirnkindom performance. Okay, they will choose some songs. Each person will have a different set of songs. Okay, it will not be the same for, let us say, Nayanthara and Trisha. They will have different set of songs which they like. Okay, so it will not be definitely same. When I looked at some of the journals like Up to Date and American Academy of Pediatrics, what they consider as important papers, there were papers, but they were all mostly related to morbid obesity, where we don't have much of the drugs which are not yet approved in our country, and some RSV, mainly vaccines which are not yet approved in our country, COVID vaccines which we are not very much practicing now, meningococcal vaccines, and majority of them were social issues. And also, how the quality of quality indices which was looked at, and non-accidental injuries like child abuse. So these are all the many of the papers which are actually shown as important papers. I mainly looking for which is appropriate for our milieu, likely to change our practice and bring some new knowledge. 5 of the 5 papers I chose, one was Indian paper that is done in our own country, and 1 African, and 3 Western, but all are relevant to our practice. The first paper came out from coordinators from Bangalore, Kempegowda Institute of Medical Sciences. This was a study on meningitis. Every decade, we are getting acute bacterial meningitis multicentric studies. Probably the last decade we had, then the ICMR took up some study, and this is another additional study, recent study on acute bacterial meningitis. The importance of this study is the molecular diagnosis was done in all the cases. What they looked at is children less than 5 years of age, 7 study sites, probable meningitis, 2019 to 2023, reverse RNA PCR, real-time multiplex PCR for the important 3 meningococcal organisms, and among the Streptococcus pneumoniae, what are the serotypes, which will have a bearing for the vaccines. So these are the centers. 2 centers are from Chennai, and 2 from north, and 1 from west. These are the other centers. The central was 1. Out of the 2004 CSF samples, majority were children less than 1 year as expected, and the majority of, as the changing trend, Streptococcus pneumoniae, which was the predominant one, followed by H. influenza and Neisseria meningitis. And among the streptococcal serotypes, 9T-ref, 6A and 6B were the most prevalent, and like it was shown in the CMC Vellore study, the CSF Streptococcus pneumoniae were mostly resistant, or at least 1/3 The CMC Vellore showed 40% resistance. Here also it is coinciding with that, nearly 32.5% resistant to ceftriaxone. Their conclusion was strep pneumoniae is the predominant pathogen, which is what we are now currently understanding, and the importance of or the inevitability of using molecular methods. It's also important to identify the pathogen and also the serotypes and also the antimicrobial resistance. The last decade, multicentric IGMR study, if you can look at it, the bottom row, nearly 70% was H influenza. After the introduction of Haemophilus influenza vaccine, now the recent ICMR collaborator study, which came out in 2021, it actually reversed. Nearly 75% became Streptococcus pneumoniae. H influenza incidence dropped down. So the observation from this study, which was from Bangalore, the antibiotic administration prior to LP happened in nearly 80% of the cases. Okay, this is the reality we have to accept. Even in hospitals, when you are doing the lumbar puncture, nearly most of the cases already would have been exposed to antibiotic. And H influenza and Neisseria meningitidis, if they have received antibiotics, the recovery was poorer. Streptococcus pneumoniae, there was not much change, but these two organisms, there was a comparison between cases which are antibiotic exposed, not exposed. Antibiotic exposed cases were less, they were able to identify the organism. Nearly 34% of the pneumococcal meningitis have been already vaccinated with PCV. The non-PCV serotypes were contributing to 22%. Even in H influenza meningitis, 17% were vaccinated. And culture showed only 4% compared to molecular methods. Again, stressing the importance of molecular methods. How do we translate into practice? Ceftriaxone with vancomycin should be inevitably be the default antibiotic to start with till the culture results are available. H influenza definitely has decreased substantially, and resistance to Streptococcus pneumoniae is increasing. We have to remember that. And you can get Streptococcus pneumoniae meningitis in spite of the vaccination. Coming to the second study, this is mainly for the institutional practice. Severe acute malnutrition, when they present with diarrhea and severe dehydration, the recommendation is to give only the oral rehydration solution, not to give IV fluids. There was a study done by Maitland. You might have heard about Maitland. She was the one who did a landmark study and published in NEJM in 2011, when she showed that actually giving IV fluids to septic children increased the mortality in African children. This actually changed the guidelines so that at least you have to know what type of practice you are having and give the IV fluids accordingly in your practice. In this study on SAM children with acute watery diarrhea and severe dehydration, why they did this study was, the recommendations say you cannot give IV fluids because there is high risk of cardiovascular compromise, cardiac failure, as well as sodium overload. That was shown by some few observational studies, and it was not actually supported by randomized controlled trials or any large studies. What stimulated this study was, in 2019, there was a study which looked at SAM children and showed that there was no deterioration in cardiac dysfunction or arrhythmias, even if you treat them with IV fluids. If you correct them, whether you correct them with oral rehydration or IV rehydration, there was no difference, there was no increased cardiovascular complication. And it also showed physiologically, they observed the Frank-Starling curve was maintained in these children. That means they did not behave like a myocardial impairment children. They behaved like a normal cardiac status. They responded to the fluid challenges like any other normal children. This study was an open label, done in an African country, and there were 6 centers. Majority of the children, all the children were between 9 months to 23 months, and they were randomly assigned to WHO, which is the current recommendation. In spite of, unless the child is having shock, even in severe dehydration, some children have to be given only ORS. That was the WHO recommendation. That was the first group, along with F75. The second group was divided into two. Some were given rapid rehydration, like normal recommendation for the normal children within 3 to 6 hours correction. Other children were given a much slower IV fluid correction over 8 hours. So this is the 5-year study. There were 272 participants, 2-year break due to COVID in 2021 and 22, 138 control and 134 liberal IV fluids. And at the end of 4 days, the mortality was no different. And the risk ratio in mortality between these two children were no different. Even at the end of 1 month, there was no difference. So liberal versus the rapid or slow, both were not showing any difference compared to ORS correction. But there were some advantages. Their hyponatremia, severe hyponatremia corrected faster, and they required less of fluid boluses when IV fluids were given compared to ORS. And lastly, the IV fluid, the oral rehydration group, nearly more than 90% had to be given nasogastric feeding. The mothers were not able to give the ORS orally, which was not the case in the patients which are given IV fluids. So their contention was current guidance may be reviewed to consider simple rehydration, same as any other child with acute watery diarrhea with severe dehydration. If you are worried about rapid correction, you can do it over the 8 hours. This mitigates a lot of problems along with the ORS, which they encountered. They did not show any increased mortality, no cardiac failure, any other complication in children who were treated with IV fluids compared to oral fluids. So this is not yet come into WHO guidelines or other things, but please watch this space for future guidelines. This is a landmark study. Now, this is a household drug nowadays, like Vicks and Amrutanjanam. Any patient with URI is going to come to you only with some LC combination. Okay, without that they are not going to come to you with a treatment. Most of them already use it and then tell that it's not working. But this is a very important drug which we have to know about because it is rampantly used and it's used extensively for allergic rhinitis and asthma. And US FDA gave an initial flagging. They said there are some neuropsychiatric, probably some concerns. And then there was a black box warning, which start telling the physicians as well as the consumers that there may be some neuropsychiatric events. So the physician should be aware of it. They have to be very careful in using it only in those refractory cases, not for every child with a mild allergic rhinitis or mild asthma. And they have to be really told about it to stop the medicine if they encounter any of these problems. So these are all there in the black box warning. So this was based on case reports. So they looked at whether there was really any problem with the Montelukast. The neuropsychiatric events were looked at one of the European Respiratory Review journal, and they showed that it was inconclusive. It was not definitely shown, especially in children. The results were heterogeneous. Some studies show some increase, some studies did not show any increase. And another study said that Montelukast is not associated with any of these neuropsychiatric concerns. So this study was taken up to look at the association between Montelukast and neuropsychiatric adverse events in children and adolescents who are on this treatment. So this is a Swedish children extract study. Because they are robust records, they were able to get these records from 2007 to 2021. Nearly 15 years, children between 6 to 17 years, the Montelukast users compared to LABA users, long-acting beta-agonist users, they looked at the neuropsychiatric adverse events in these children. There are nearly 75,000 eligible children. The Montelukast group was nearly 26,000. And the LABA group was 47,000. Follow-up was till the time they were using the drugs. That was the follow-up period. And Montelukast group, there was 310 out of 26,000. And in the LABA group, 566 out of the 47,000, they had some neuropsychiatric events. The hazard ratio, that is what is the possibility of getting this was no different between the Montelukast group and the LABA group. Okay. And if you look at the per patient years also, there was no difference. 2.39 compared to 2.41 between the Montelukast group and the LABA group. There was no difference between the Montelukast and LABA groups for specific neuropsychiatric adverse events. So this was again corroborated from multiple other studies. But please remember that this study is not to talk about the indications or advantages of Montelukast. This is only for the safety concern. So okay, please remember that I'm not talking about the Montelukast, whether it is indicated or not indicated. I'm talking only for the safety part of it. That is the take home in the study. The fourth study about, I'll just rush through, the iron deficiency with anemia, without anemia, and the basal ganglia iron content. So this they looked at the MRI level of the iron in adolescent children who did not have anemia, but they had less iron based on the serum ferritin levels. Okay, not anemic. That means the hemoglobin levels were normal, but even when they had the hemoglobin levels were normal, if their serum ferritin was less, these children have reduced the brain iron content, especially in the caudate nucleus and the putamen. This was all associated also with not only with the reduced iron content, or also with certain neuropsychological behavioral changes in these children. We know that iron is important. There was a landmark study again from Pondicherry which showed that iron supplementation is very effective. That we all know. But the important point in the study is, of all the children they tried iron supplementation, none of them were being given any regular iron supplementation. Though there is a national iron supplementation program, national anemia control program, in practice this is not happening. Lastly is a pediatric surgery study. So appendicectomy versus antibiotics. Recently, antibiotic alone is considered as a choice for uncomplicated appendicitis. Most of the pediatric surgeons we talk about, they are totally against it. But this study was done just to look at it's a randomized control study. The parents are willing to wait without doing the appendicectomy. They were given the antibiotic choice. 7 different centers it was done, mostly from European countries and Singapore, and they showed that appendicectomy was definitely associated with less complications, and children who were given antibiotics, later they had to resort to appendicectomy in nearly 30% of the cases. My acknowledgement is mainly the good things about WhatsApp University. Many of these studies I came to know about, then I looked at regular journals, and contributors like Dr. Alok Gupta, who regularly contributes such good studies, and also from colleagues from ResearchGate. And thank you for your kind attention. Many of the changes which I told was contextual, and it may be varying from place to place, and we have to keep on looking at these changes. Thank you so much.
Thank you, sir. A nice presentation. The ultimate key message, whatever the research studies being done, the outcome should reach the beneficiary, that is children. Thank you, sir. Speaker is our respected teacher, the teacher of teachers for the last 50 years or more than that, the senior most person in the whole state of Tamil Nadu, who is still enthusiastic in his academic career, teaching students, guiding all postgraduates in various institutions. Professor M. Ramasamy, fondly, respectfully called as MR, sir. I invite him for his lecture, please.
Good morning. Let me extend a warm welcome to all my colleagues and also delegates from outside Coimbatore. And what I'm going to talk to you is about a bit of original work that we have done at our institution in the past 6 months or so, along with my colleagues and also postgraduate trainees. And this is about the usefulness of artificial intelligence in general pediatric practice, remembering my mentors, 1964-68 New York City, And then, thanks to the organizers, they are resurrecting some of the fading pediatricians of the 21st century like me into the mainstream of academic activity. Thank you very much. And I've already mentioned my gratitude to my colleagues at the hospital who feel that I have fallen into kind of a wrong type of romance, especially with ChatGPT and ChatGPT 5. And I don't think I have done into the wrong type, but I think my brain is getting activated by almost this kind of activity. And AI can support you many different ways. I mentioned 8 of them. The focus of my talk is only on the second and the third one, namely specific diagnosis and the differential diagnosis. And main objective of my brief talk is to show how useful it is, and also a little bit of statistics where I can show you there is a moderate degree of a strength or association. Now, this is the scenario 1. 1-month-old baby got admitted into our ICU, just less than 24 hours of fever, irritability, and poor appetite. Along with that, there was an inflammatory swelling over the left cheek. And then I happened to see the child within a few hours of admission, and I agreed with the finding. I pressed on the parotid gland. I thought the pus exuded from the stents and stuck. Immediately my colleague said, "No, sir, it is not pus, it's the curdled milk." And then, of course, ultrasound didn't support the diagnosis of parotid gland enlargement. And my intensivist, of course, have the diagnosis of sepsis, and child was admitted, and full sepsis workup done, broad-spectrum antibiotics to cover aerobic and aerobic organisms, and as well as opportunistic pathogens. Baby did very well, and this is the picture. Indeed, if you were to look at the picture for the first time without any history, you would think of a condition called infantile cortical hyperostosis. That is not the situation here, because less than 24 hours duration, painful soft tissue inflammation, the baby did very well. And we know, but 9 case scenarios I'm going to tell you. This is the first one, like the Navagraha. When we go to the temple, we go around. And the methodology we did was make a clinical diagnosis and then feed the material into the AI and ask the AI to give the diagnosis and compare the two. That's what we did. And then when we prompted the AI with this information, this is how AI categorized: infective, non-infective, and systemic. It mentioned even mumps and Kawasaki. It failed to mention, the Caffey's disease probably was considered necessary. So the 8-month-old thriving infant, again one day fever. When we looked at this baby, what surprise was there was a bilateral symmetrical non-pitting edema. No signs of inflammation, both hands and feet. And I had not seen anything of this in this particular age group. My mind was thinking about neonatal Turner syndrome. That's all I could think of. So for want of anything better, we simply called it, because as exam is normal, basic workup also was normal, we simply called it allergic edema. This is the picture. For want of any better expression, we simply called it allergic edema. Then we again fed this into the AI. AI immediately came with an answer. This would be called benign acute infantile edema. And infantile is a variant of acute hemorrhagic edema or variant of henoxaline. I put another question: why did not it fit under pressure? It said this is a proteinous exudate that comes out. That's why it doesn't fit. And that doesn't give pitting on pressure. So that's the second one. So the characteristic self-limiting illness, 4 months to 2 years, and the fever, edema, purple. Indeed, this baby not only had the bilateral non-pitting symmetrical edema, not only by induration proximity, but the whole thing went away in 48 hours. The baby became completely normal. And then this is a third scenario. This suppose happened to see this baby on a phototherapy for a breast milk associated jaundice diagnosis established by the neonatologist. All the criteria were fulfilled. And so again I fed this into AI. AI agreed with the diagnosis. It gave also immediately a very quick differential diagnosis. It also went on to say a condition that would mimic this very closely is the Crigler-Najjar type 2. And then I asked, how do you differentiate? A Crigler-Najjar type 2, it lasts lifelong. Phenobarbital will bring it down. Whereas breast milk, you have temporary cessation of breastfeeding, and some formula would change the things better. So that we have the clue. So, and this is the criteria, and even mechanism is mentioned there. And then this is a 2-year-old. episodic breathing difficulty from the age of 6 months, stridulous breathing, lasting for a couple, maybe 10 or 15 days, resolving to a great extent with conventional measures. By then the fourth episode, 2 years, arrived. We had a very astute young pediatric pulmonologist at our hospital. He listened to this baby and he observed the biphasic stridor, which meant subglottic valve obstruction, and he had only 2 conditions to worry about: vocal cord dysfunction and subglottic stenosis. We fed this again into the AA. AA came to a similar conclusion: subglottic obstruction, either vocal cord dysfunction or subglottic stenosis. And I'll show you. Yeah. No, I think we see where do I show the movie? Let me see. Can you help me there to show the movie here? Where do I press? Okay. Just. No, there is a 10-second movie. Can you show that? Just. Okay, thank you. You could see, you could hear, you could see in drawing, you could even hear the biphasic. I don't know whether it's audible, but the biphasic nature of the stridor immediately gives a clue the level of obstruction is subglottic. In the pediatric pulmonologist said, AA confirmed it also. And of course, fibrotic nasolaryngoscopy endoscopy showed subglottic stenosis. They eventually required a tracheostomy. Now, this is actually my own housemate's child, 4-year-old. He presented with blisters on the inside of the sole, 5 days duration, no lesions elsewhere, and was recommended mupirocin and levetiracetam, no resolution. I'll show you the picture. These are the pictures he mailed me. As a pediatrician, I thought it was just a bullous impetigo. That's the commonest. But that is not the site. This is not the site to get bullous impetigo. So again, I prompted the AI, and AI, before that, I think, no. The AI mentioned unequivocally friction blister and gave a differential diagnosis. I mailed this to 2 dermatologists. They came to the same conclusion: friction blister. Now, there are also reasons are also mentioned why it's called friction blister. The 7-year-old boy, full-blown congestive heart failure, all the manifestations, landed in our emergency room. My colleagues and residents thought, they agreed it was failure, but they thought it was an undetected, undiagnosed, severe congenital heart disease, left to right, volume overflow. That was their impression. And the past history of wheezing from the age of 3, but just a few days each time. And then this is the picture and ECG consistent with congestive heart failure. And then that was impression by our people. But then AA completely disagreed and said, no, it is acute myocarditis, cardiomyopathy, and gave the reasons also. So the priority of the causes. And then this is an 8-year-old boy, multiple episodes of hematemesis from infancy, prematurely born, ICU care for about 6 weeks. And my doctors made a diagnosis of portal vein obstruction, extrahepatic. And AI agreed with the diagnosis and mentioned the reasons also. Repeated hematemesis, no signs of liver failure, prominent spleen, no, of course, history of neonatal factor. It was actually, umbilical catheterization was done as a part of ICU work during the ICU stay. And this is the picture. This is the Doppler picture, and this is the the varices being coagulated. And now this is a 10-year-old boy, 6th standard in a co-educational school, only child, parents in their 40s, repeated retching and bringing out sputum with a drip of blood. That was the only complaint, symptom for 48 hours. And 3 days earlier, he bled from the anterior nostril and settled down, and negative past family history. When we looked at him, he was a very cheerful child, excellent demeanor, very comfortable. But then suddenly he would complain of very severe pain and the discomfort behind the sternum, and next moment he would be all right. And our impression was to think in terms of functional. Of course, we had the Mallory Weiss and the differential diagnosis. This was our impression, and AA, mentioned it is indeed psychomotor functional conversion, that will be the top priority. Now, so these are other conditions it mentioned, the differential diagnosis. And this is a 9-year-old adolescent boy. We are in for a surprise here. I don't think any of you would have run into the situation. If you run into, please let me know. An adolescent boy, 18 years, product of IVF, 3 kilo. I've been following the child from the time he was born with a growth chart. Excellent longitudinal growth all along the 3rd and 5th percentile up to the completion of pubescence. Absolutely. Now, these are the measurements. I requested the AA to plot it for me in less than 30 seconds. You know, this is how the AA plotted it. The red is the median, that is the red line, and then the blue line is the child's growth all along the median, not much of a deviation. So acceptable. Growth trajectory is acceptable. Now, this is actually the bottom interrupted red line is the child's height, and the blue interrupted line on the green on the top, that is the target height and the range. And of course, you see how far below. The child's height very much below the target range, very much below, unacceptable. And then AA said, you know, once AP is closed, it requires an explanation. And we had an explanation for this child because the child had B group, he was born to O group parents. Biological impossibility according to Mendelian laws. So AA also mentioned the same thing. So some error might have occurred at the embryo level, at the IVF center. Okay, now, then what I did, with 9 of these cases, I used, Cohen's kappa, that's a statistic. The AA did it for me. And then I put this, and the AA looked at the similarity score. Wherever you find 1, excellent agreement. Wherever you find 0, no agreement. Between 0 and 1, some kind of a mild, moderate agreement. The AA did it for me in less than 30 seconds. It's a statistical tool. I didn't know anything about a statistical tool till AA taught me. And then you see that now, metric. 9 exact match, 45, and 50% odd overlap, 45, mean similarity, and then Cohen's kappa 0.42. So is it a boon or a ban? As far as I am concerned, in general pediatric practice, it's an excellent tool if it is used intelligently, appropriately, of course with some kind of background knowledge and experience. And as a matter of fact, as a general pediatrician, your knowledge base will be as close to that of a subspecialist, any subspecialist. When you're going to interact subspecialist, you will speak to him with the knowledge. So that will really take you up to almost any kind of subspecialist in any kind of a discipline in pediatric practice. And then it's a powerful tool, not a replacement. Judicially, as an assistant, is excellent. It's not an authority. It can significantly enhance the care, in your office as a hospital, but the challenge lies it integrate safely, ethically, and equitably. Just before I came to the podium, my colleague asked me, will it kind of blunt your brain capacity? Will it kind of ever replace you? I'm afraid not. As a matter of fact, it will make you more and more curious. It will make you go more and more into the subject. It will make you more and more knowledgeable. And will it ever replace a doctor? Never, never, ever. Because doctoring is basically comforting, relieving, curing. That AA cannot do. So it will never replace a doctor. All AA can do will give you up-to-date information in a matter of few seconds. As a matter of fact, as I was coming towards this conference, I posed a question to AI, why is that there is no pitting in the edema of the child that we saw? And the AA said, pitting will occur when there is only a fluid in the interstitial compartment, watery kind of fluid. Pitting will not occur if it is a gelatinous fluid that occurs. And that's, in other words, it's a jelly in a sponge, no pitting, you have an edema. Water in a sponge, you have pitting edema. See, this is the amount of knowledge, information it gives you. It even gives you references. Thank you very much for this opportunity.
Thank you very much, sir.
Thank you,
For
sir.
the nice presentation. And using AA should not become too dependent in future. Still, the systematic, disciplined clinical approach holds good. Thank you, sir.
Thank you, sir. We are deeply grateful for the knowledge you have shared and the time you have devoted to KONGU PEDICON 2025. May I request you to proceed to the faculty lounge to receive a small token of our appreciation. Our volunteers will be happy to guide you. Delegates are invited to post their questions for the speakers through the question and answer link shared on the KONGU PEDICON WhatsApp group. Speakers will also be responding to these queries on the same platform. The session receiving the highest number of questions will be honored with the Trending Topic Award, and a lucky draw will be conducted from among the delegates who submit questions with a prize for the winner. We encourage your active participation to enrich the discussions. Introducing the second session for the day. We are incredibly fortunate to have with us the chairperson for the next session, Dr. P. Nalini. Ma'am is a Padma Shri awardee, former director and professor of pediatrics at JIPMA, and founder of Hemophilia Society of Pondicherry. We invite you onto the stage, ma'am. We invite Dr. Bala Ramachandran, who is presenting on sudden collapse in EMD, case-based rapid response. We welcome you to the stage, sir. We invite you to the podium to start your lecture, sir.
Hello, good morning, and happy Independence Day to everybody. I have been called as a Stepney for somebody who's not here. Dr. Bala Ramachandran needs no introduction. He walks in intensive care, he breathes intensive care, and he thinks always of pediatric intensive care. I've known him for many years. He's a very distinguished person in pediatric intensive care, working in Kamakoti Child Trust Hospital for many years. I am also waiting to hear his lecture. It's always a pleasure to hear him. Thank you.
Thank you so much for the kind introduction, madam. Good morning, all of you. It's a pleasure to once again be here at KONGU PEDICON. I want to thank the organizers, and in particular Dr. Rajendran, for having invited me for this event to this lovely city of Coimbatore. So let me move on. The topic assigned to me is sudden collapse in the emergency department, a case-based rapid response. These are my disclosures. Okay, so let's move on. So what is, sudden collapse? Sudden collapse is an acute failure of the vital physiological systems, which needs a structured response. That structured, I want to stress on it, rather than a haphazard saying what happened, Is he moving? Is he, whatever. The structure is important. This allows us to rapidly recognize the condition and manage it as quickly as possible rather than beating around the bush. Okay. The learning objectives for this session are how to do a rapid assessment, understand the possible causes when a child or anybody for that matter collapses in front of you, what are the relevant investigations here, and the basic steps of the initial management. I want to stress here that I am not going to speak anything new. This is simply a review of what all of us have been taught and all of us have been practicing over the years. Nothing much has changed, but it will serve as a refresher for those of us, especially those of us like me beyond a certain age. We tend to forget things. So it's not just a hair we lose, we also lose memory. So it will serve as a refresher for us. Okay. Unfortunately, not every child who comes to the emergency room has a diagnosis as clear as this. They're not going to come and tell you what is going on. It's up to us to find out. So let's get to the case scenario. We have a 14-year-old boy who comes to the emergency room. Is there a timer somewhere? Oh, there it is. Got it. Okay. Thank you. Yeah. He's brought by his friend because the child was feeling giddy. He was walking into the emergency room and he collapsed in front of you. So what would you do? Can I ask the members of the audience? Anybody? Don't make me pick volunteers. Vitals. ABC. Thank you, Dr. Ramachandran. Thank you. Check for breathing and pulses. First thing, right? Okay, this is what has been drilled into us by pals over and over again. Okay, so the immediate action, we're going to look at the ABCs, check the airway, make sure it's open, suction if needed, breathing, assess the chest rise, and if they're not breathing, assist ventilation. Circulation, check for a brief time. Don't keep on feeling for the pulse for 10 seconds. If you can't feel a pulse, you need CPR. Then establish venous access, again, as quickly as possible. Don't, again, keep on trying for 5 minutes. If you can't get it in 90 seconds, intraosseous. And then check for reversible causes. This is the one thing which is important for all of us to remember, the HNT method. So the immediate assessment of this child, central pulses were present. He was breathing well. So what do you think is going on? He's breathing well. He doesn't really need his airway is open, his breathing is okay. Okay, and pulses are felt, circulation is reasonably okay. All right. So this is going to be a little hard to see. It's hard for me to see. It's going to be very difficult for all of you to see. But it's a very quick, BLS algorithm. First, make sure the child is in a safe location. Check for responsiveness. Ask for help. Again, I'm just talking on this as a refresher. Okay, this is not a PALS lecture. If you have EMS, and we do have EMS in India now, thankfully, so activate it if appropriate. This child is already in an emergency room. And then look for breathing, or is he only gasping? If he is not breathing, is only gasping, or there is no pulse, then you go to the right side, you provide rescue breaths, and if necessary, start CPR. If this child is breathing and pulses are felt, so therefore we monitor him until additional help arrives in the emergency room, we can proceed to the next step of management. Okay, the next step would be the assessment triangle and primary assessment. So here this child is a little drowsy, no increased work of breathing, he's pale. These are the vital signs, respiration's 18, saturating well, heart rate 120, BP 74/40. He's drowsy, GCS is 14, sugar is normal, and he's cold and pale. What happens now? What is the physiological status here? I'm sorry? He's in hypotensive shock. BP was low. So what are we going to do now, management? We put in 2 IV cannulas, give him the fluid bolus of any isotonic crystalloid, 20 mils per kilo. Do the basic investigation. What basic investigations are we looking for now? One is the blood sugar. What else? Chest X-ray, okay. Electrolytes, blood gas, right? CBC, all of those kind of things, because we need to know, is he acidotic? Does he have a high potassium? Does he have a very low calcium? Is his sodium very low? All of these things are some of the causative factors for such a situation. Okay. So what could be the cause? You have this long list: volume loss, sepsis, arrhythmias, dengue, allergies, poisoning, etc., trauma, syncope, and seizures. Now his friend says that the patient has been well until now. He doesn't look dehydrated. There is no history of or no obvious signs of any external injuries. So this rules out quite a few of these causes, right? So these are the causes that we have left: arrhythmias, allergies, or bites, poisoning, syncope, or a seizure. So going to the theoretical aspect here, if you have a sudden collapse, you have these possible differential diagnoses. You can have a cardiac cause with arrhythmias, etc. Myocarditis can collapse suddenly. You can have a respiratory cause, airway obstruction, asthma, etc. Neurological seizures, very, very common. And then raised ICP. Metabolic causes, again very common: low sugar, which we've already ruled out, sodium imbalance, calcium imbalance, and then shock and sepsis, hypovolemic shock, etc. These are in general. So what is the commonest cause of sudden pediatric collapse in your experience? Commonest cause of sudden collapse? Vasovagal? I think people are, maybe I'm not phrasing the question correctly. The commonest cause would be respiratory or cardiac. That's what we see all the time, right? Vasovagal would come lower down. It's not that common. Maybe the question wasn't clear, so, my fault. Okay, so back to our patient. Heart rate is now 110, BP is slightly better, CFT is still prolonged, still drowsy but not fully conscious. Liver is not enlarged, the lungs are clear on auscultation. He really can't give you a history, and the friend doesn't know anything more, and you get these basic labs back. A venous gas, in the emergency room, a venous gas is more than adequate. You don't need to poke him for an arterial blood gas. Even a venous lactate is useful in this situation. So it gives you 7.28, CO2 of 32, bicarb of 16, -8 base. Sodium is okay, potassium is okay, chloride a little bit on the lower side, lactate is 4.9, slightly elevated. So what do we do next? Okay. So we have now gone on. It's about 30 minutes later. BP is a little bit better, and we've determined that he is fluid responsive. Cause, we're still under evaluation. He's got metabolic acidosis. Lactate is high, bicarbonate was low, pH was on the lower side. Okay, so now further management, if you have point of care ultrasound, this would be the time to do it. And then we start a second bolus of 20 mils per kilo. Parents are on the way, the family is on the way now, and so let's move on. So what are the etiologies? These are the 5 causes that we spoke about, the 5 remaining plausible causes. And I wish we had AI here. It would have, I'm sure it would have picked this up. Thank you, Dr. Ramaswamy, for that wonderful lecture if you're here. So now if you look at allergy, there's no rash or wheeze, no angioedema, etc. No bite marks, no history, no pain. The child was normal. He doesn't fit any toxidrome. Seizure, yes, but he wouldn't really be hypotensive immediately after a seizure, right? So it's unlikely. Vasovagal, again, vasovagal syncope, the minute they fall down because of a low blood pressure, the minute they fall down, the BP will come back to normal. So ongoing hypotension is unlikely. However, I must say that the first 3 causes are difficult to rule out completely at this stage. So our initial investigations, which we do in such situations, we need to do an ECG for arrhythmias, etc., conduction blocks, signs of myocarditis, blood glucose in anybody, not just small infants, even older children, adults as well. Blood gas, as I've already mentioned, portable X-ray, as Dr. Janani mentioned earlier, and point of care ultrasound, and then electrolytes, very, very important. Okay. Beyond this, what should we do? We can do echocardiography if the child is now a little more stable and you have access to the cardiologist. Neuroimaging, if appropriate, after the initial stabilization. And then other, labs such as ammonia, thyroid, which are going to take some time to come back anyway. Sepsis workup, and then if you're suspecting a toxic ingestion, toxicological investigations. Okay, now I talked about the 4H and 4Ts. Very useful for us to remember, especially when, in an emergency. These are reversible causes, and the H's are hypovolemia, hypoxia, hydrogen ion acidosis, hypo or hyperkalemia, hypothermia, and hypoglycemia. It's not really 4 H's in this case. It would be more like, I would say, 6 H's. And then the T's are tension pneumothorax, tamponade, toxins, and thrombosis. Thrombosis, of course, is not that common in children. We're talking about cerebral venous sinus thrombosis, or even more rarely, a pulmonary thromboembolism, but doesn't happen. Maybe in a child with a congenital heart disease, it's possible, but not very common. But this is useful for us because it is going to, if you apply this and look for these, you will be able to diagnose reversible causes immediately so that you can do something about it. Okay. All right. So what happens now? Second bolus is going on. Heart rate has come down. It's 96. BP is slightly better. Cap refill is better. He is conscious. Drowsy is not as drowsy as he was. And the family has arrived. So now we have a twist in the tale. The grandfather takes prazosin for hypertension. This child was prescribed calcium and vitamins the previous day. The grandmother gave him prazosin instead of calcium by mistake. Do we see this scenario? Maybe not prazosin, but we see it all the time. We see it all the time. Oral anti-diabetics, calcium channel blockers, antihypertensives, we see it all the time. So this child was admitted for observation and he recovered uneventfully. Okay, so this is, even though this child does not fit the classic toxidrome, it's good for us to go through the algorithm, look for the treatable causes. We've ruled out most of the treatable causes, like, we saw the 4H and 4Ts, there is no pneumothorax, there is no pneumothorax you picked up on your bedside ultrasound or chest x-ray, there is no pericardial tamponade, all of those things. And so now we find out that he's got hypotension and he was previously normal, and then we find out that he's probably received prazosin by mistake. Okay, so what are the learning points here? Early recognition and triage is important for these children because you have to identify the condition early, and if you use early warning scores, number of them are available, they will help in the triage process. Okay, very easy to use. Simulation and team training, this is important because invariably what happens is we get a chaotic response if we haven't practiced. And I'm talking from personal experience in a large tertiary care ICU. For years I noticed that CPRs inside the ICU were very chaotic because different people would start throwing out commands and the person who's executing doesn't really know whom to follow. And so it was like, I would think they have done something, they would think somebody else has done something, and eventually nothing gets done. So then we started doing a simulation-based training, and it's become much, much smoother. It's not difficult to do. Even if I don't know the details of how to do it, but I rely on others to do it for me. Okay. The other thing which would be very useful for us would be a standardized protocols. You know, all of us are familiar with PALS and BLS, etc., the algorithms. The problem is, and I'm not ashamed to say this, I also forget these over time, because if you don't practice it daily, you're not going to sit and read the latest algorithm. We have too many things to do. So the best thing for us to do is attend a refresher once in a couple of years so that it stays in our heads. Okay. So the standardized protocols, and then make sure that you have this common sense. Make sure you have the critical equipment available, and then keep assessing yourself with periodic audit so that you can find out where we lack things and improve them. I want to acknowledge this person for this talk. He helped me a lot. Dr. Sudeep is one of the senior consultants in my ICU. He was my student as a fellow, and now he's as a consultant. He really helped me with this talk, so thank you, Sudeep. And I think I have the, so you need a swift and structured response. PALS algorithms we've talked about. Maintain team readiness, and of course, early recognition saves lives. Thank you very much, ladies and gentlemen. Last slide. If you look at this, we have a tendency as doctors, especially as ICU doctors, to look at the monitor and the lab results. We should look at the patient, not say, wow, your cholesterol has really got me worried, and here you have an obvious diagnosis staring at you. So look at the patient and not the labs or the monitors. Thank you very much, ladies and gentlemen.
Thank you, Dr. Bala. It was an excellent lecture. At least I had a recap of whatever my knowledge was. Any questions or any additions? There are many people here involved in intensive care.
Seeing as there are no questions currently, we'll have them at the end. I now invite Dr. K. Sasidharan, an expert in acute care nephrology and critical care, to the stage for the next lecture.
Good morning, everyone. At the outset, I thank Dr. Rajendran sir and KONGU PEDICON organizing team for such a great opportunity and choosing more relevant topic. Within next 20 minutes, what we are going to do is everybody has to gain something out of the lecture. That is the goal. So I am going to discuss about preventive AKI, preventing AKI in children, a clinical approach. The clinical model I am taking here is two clinical models. One is a patient who is coming to hospital without kidney injury, and the goal there is they have to get discharged without any kidney injury. Coming without kidney injury and going out without kidney injury, that is goal 1 in clinical model 1. Clinical model 2 is somebody is coming with a early kidney injury and it should not progress to go to dialysis, and we have to catch it early and treat it early, and without any further AKI, we have to discharge. So these two clinical models you keep in your mind. This will help you to correlate with the presentation and apply it in future. So there are principles of AKI management and AKI prevention in children. Now in 2025, we speak quite a lot by AKI prevention. So this is because of ISN, International Society of Nephrology initiative on 0 by 25, but we have not reached 0 by 25. At least by 2035, we will reach 0. So this is like 10 commandments. So this 10 commandments is the whole presentation. So we have to understand the subclinical AKI and risk for developing AKI. This is first step we need to do. So we have to identify early. For identifying early, there are many tools. There is something called risk stratification tool, which I will discuss. Third step is circulatory volume. Effective circulatory volume optimization is the first step in critical care of any critical children or any hospitalized children for that matter. Optimize the mean arterial pressure. If you are not achieving by preload optimization alone, try to take the help of vasoactive agents, conventionally called inotropic drugs. Then optimize the oxygen carrying capacity. Some children may require hemoglobin optimization, that is anemia management. and then monitor and maintain electrolyte homeostasis. This is very, very important. Hypo and hypernatremia, hypo and hyperchloremia have influence on AKI, that is acute kidney injury. And monitor and avoid excess fluid accumulation. There is something called target fluid overload percentage. It has to be always kept less than 5%. Remove and avoid all non-essential nephrotoxin. This is a very interesting terminology, non-essential. So any nephrotoxin is non-essential, no? So why we call it non-essential? Example, a patient may go for contrast CT. That may be mandatory, but how to choose the contrast? That is called non-essential nephrotoxin. Then perform appropriate therapeutic monitoring of all drugs. So that is dose adjustment. This is very, very, very important. And there is something called context-specific interventions. In 20 minutes, 100% I won't be able to cover all 10. So I am going to focus on 3 categories. One is AKI risk stratification. Another is fluid and electrolyte optimization as a preventive strategy. And then kidney safe medication strategy if time permits, 2 case scenarios. So what I am not going to discuss, anemia correction, what is the threshold to transfuse, how do you handle hemoglobin in 2025, that I am not going to discuss. Context-specific intervention, how do you decide context-specific intervention in acute kidney injury? I may not be able to discuss because the time may not permit. First we go to risk stratification. For that you have to understand about what is subclinical or early acute kidney injury. This is how the kidney injury develops. Normal kidney, increased risk, progresses to damage, then reduction in GFR, then kidney failure. So what happens in GFR? GFR goes down. If it goes down more than 50%, then only it will be appreciated in your creatinine. And then the injury progresses as the GFR goes down. Now, in the GFR down kidney failure state, we call it as acute kidney injury. The prior state, the increased risk and the start to damage, this is called subclinical AKI. Why the subclinical AKI is important? The injury can be easily reduced and kidney can be preserved to the previous normal functional state. That is why subclinical AKI becomes the point of concern here. So now we have to find tools to find out the subclinical AKI. So we have a toolbox. I am going to discuss about 4 tools. Tool number 1, that is called the AKI staging. This is KDIGO 2012 guidelines on AKI staging. So only one thing you have to concentrate, because we are speaking about early, stage 1. Stage 1 is 2 times the baseline creatinine, or 0.3 milligram per deciliter rise in creatinine, or less than 0.5 ml per kg per hour urine output for 6 to 12 hours. Okay, this is the tool number 1. What is the basic limitation in tool number 1? We need baseline creatinine. Do every pediatric patient is going to have baseline creatinine? Most common answer is no. So how do input that number? So there is something called imputation method. How do you input that number? You have to use a formula. So what is the formula which is most appropriate as of now available? This is the CKID creatinine formula. This formula was derived based on the large data set in Cincinnati Children's Hospital by group of Dr. Stuart Goldstein. So this is serum creatinine equal to 0.413 into height in centimeter by 120. This is the formula to calculate the baseline creatinine. Based on this, you have to decide whether 2 times increase has happened. Go to the tool number 2, AKI etiology based on grouping. This is a simple grouping method which we have done from school time. So reduced renal reserve is one group, primary renal disease is another group, drugs is another group, drugs or toxins, and whichever is not classified in these 3 buckets come to the 4th bucket. So that 4th bucket is not specific. Non-specific is the 4th bucket. So why this is important? In this 4th bucket, it helps you to decide about the therapy. So we have discussed something like context-specific intervention. For example, HUS, you may do plasma exchange. For thrombotic microangiopathy, you may decide about some medication. For some types of HUS, you may decide about some complement-based therapy. And some patients like rapid progressive glomerulonephritis, you decide about methylprednisolone pulse therapy. So for septic patients, you may decide about source reduction. All the context-specific interventions you can decide by grouping. Now coming to risk screening, this is again important. This is a very simple tool, and if you do this risk screening checklist, if you get no response for more than 3 factors, highly likely that your patient may develop AKI during this episode of admission. This is what it says, during this episode of admission. That is why you can be more careful about that patient. This is your tool number 4. So there is a risk screening checklist. There is something called renal angina index. This is specifically used only in ICU. This is a scoring system, 0 to 40. If your score is more than 8 or more than or equal to 8, this patient has high incidence of AKI during the episode of hospital stay. So finally, we have spoken about 4 tools: AKI staging, and then etiology based grouping, and then renal angina index, and then simple risk screening checklist. So these are all the tools to find out your so-called subclinical or early AKI. Second thing for discussion is fluid selection, optimization, and electrolytes. In this, I am going to touch upon 3 things. One is, what is optimal fluid therapy strategy in 2025? Originally, we used to say we give fluid bolus in a shocked child and see whether the BP is increasing. That is called response. Now, the one question has been converted to 3 questions. So you have to give fluid infusion and see whether was the fluid infusion is effective. Third question, most important, is did fluid infusion exert adverse effects? That is the most important third question added. What are all the adverse effects? Lung edema is an adverse effect easily found out by B lines in the ultrasound. Was hemodilution significant? By monitoring your hematocrit and hemoglobin, you can understand this. Did the right ventricular function deteriorate? Again, this is easily identified by a bedside POCUS echo. Did the intra-abdominal pressure increase? Clinical examination surface. If you need, you can do a intravesical pressure monitoring. So if all the 4 question answer is no, then only the fluid resuscitation is justifiable in 2025. This is called safe fluid therapy in 2025. Now about maintenance fluid. Always we are confused about maintenance fluid. Though the proposals of Holiday Segar has came in 1950s, still we believe it, so most of the time we start with 100% maintenance fluid. The first order is IV maintenance fluid administration. In current practices, 70% of Holiday Segar estimated volume for any hospitalized child, for any, underline any. Isotonic, that is 5% dextrose containing solution, is the optimal choice, at least a reasonable starting point, and further restrict or liberalize based on the disease specific status. Transition to enteral as fast as possible. This is the golden rule. Even in ICU, HDU, ward, independent of that, the golden rule is transition to enteral as fast as possible, because please do understand, whatever fluid therapy you do, intravenous is a non-physiological method of administering fluid. Never been God has made the body for intravenous fluid administration. That is the method we identified as convenient and followed. Titration based on further fluid need and response is equally important. Third thing, we wanted to give restricted IV fluid. We want to be very careful about maintenance fluid. Every strategy followed, but in critical care, even if you follow every strategy in hospitalized medicine, you may end up in problem. So the fluid overload more than 5% happened. So that time this tool helps. This tool is simply giving furosemide and seeing the response. So initially it was simply giving furosemide. Now we have complicated it a little bit. So because we understood furosemide a little bit more. So any child with oliguria, first you see whether the patient is euvolemic or hypervolemic. MAP has to be more than 50th percentile, lactate less than 4 millimole. This is safe to give furosemide. And albumin has to be more than 2 gram per deciliter. Why? Because in hypoalbuminic patients, your furosemide concentration reaching in the renal tubules are lesser. So it may not act great. So that is why albumin is very important. If everything is okay, then you can go for something called FST, that is furosemide stress test, we say. And there are 2 ways of doing it. Either you give 1 milligram per kg bolus followed by 0.04 milligram per kg per hour as infusion and see the response, or you give 1 bolus and see the response. Either way you can do, both ways are accepted. And now we go to the third portion of the discussion, medication selection, kidney-friendly approach. This is very, very important because drug-induced kidney disease is 16% across the world. 16% is not a lesser number, we all understand. That is why this becomes very important. It may be a primary cause, or most commonly it is a precipitant cause. Tubular diseases are underreported, but they are equally problematic. So this is a ninja system which was used in US. This is called a nephrotoxic injury negated by just-in-time action. It's very simple. They created a list of nephrotoxic medication. This is the list they have created. Using this list, they started screening the patients and identifying the risk and preventing the administration of these medications as far as possible. This is the way they have prevented 16% and it came down to 4%. There is a significant reduction. What we can do? We can do using a simplified list. This is the simplified list. The drugs which are causing hemodynamic changes and causing AKI, acute tubular injury and causing AKI, acute interstitial nephritis and causing AKI, intratubular precipitation and causing AKI, and osmotic nephrosis and causing AKI. If you keep it as a reference card, and if you go through this in every treatment chart, either your clinical pharmacist or your nursing head or your quality nurse, anybody can go through this using the card, and they can identify that how much the patient is prone with the drug-induced kidney injury. Now coming to the case scenarios, how we apply this becomes very, very important. We have discussed all the concepts. How do we apply this? This is the case scenario 1, a 3-year-old male child weighing 16 kg, fever and cough 9 days, tachypnic at presentation, started on high flow, the child requiring 45% FiO2, received IV antibiotics, no clinical features of fluid overload, urine output is 0.5 ml per kg per hour, disease trajectory looks progressive, blood urea is 86, creatinine 1.6, organ involved is lung and kidney. The lung you are seeing, one side there is white out. Further evaluation, left lung consolidation with pleural effusion. The pleural effusion is actually empyema, and pleural fluid showing 40,000 cells and 85% polys. So in this child, creatinine is 1.6. What do we do? So here 3 things we are doing. We are doing the antibiotic selection appropriately. We are not giving vancomycin, we are starting linezolid. And we are doing a source control. Left ICTD is placed, and this is a pneumococcal infection which has been found, and appropriate antibiotics have been given. And CT has been done, and child has been taken up for VATS. So there is nothing renal focused medication, things have been done here. But this is the treatment for creatinine 1.6, and creatinine has come down to 0.4. That is how the secondary preventive strategy works. This is a case scenario 2, where it is a 7-year-old boy weighing 21 kg, fever 3 days, 1 week prior, fast breathing, 1 episode of generalized tonic-clonic seizure, seizure controlled with lorazepam, loaded with anti-epileptic drug which is fosphenytoin, BP is 164, 116, that is a hypertensive child, organ involved is kidney and CNS. Further evaluation, the child is drowsy, tachypnic, saturation more than 96%, BP persisted to be systolic blood pressure more than 150, pH is 7.32, creatinine 3.2, urea is 96, urine microscopy, protein 3+, and granular casts are present. How do we manage this child? This child, urine analysis is showing nephrotic range proteinuria plus hematuria, and USG KUB is showing renomegaly with increased echoes. Child has been started on Lasix infusion, and urine output has improved. Child BP controlled with 3 antihypertensive medications, and the child was considered to have crescentic glomerulonephritis. Clinically, we call it as rapidly progressive glomerulonephritis. The appropriate treatment, the context-specific treatment is IV methylprednisolone pulses, which has been started, and the child has started improving. So admission creatinine is 3.2, but still there is nothing except the context-specific intervention MPS. There is nothing else towards only kidney. So the secondary preventive approach helps in salvaging the child without dialysis. This is my last slide. So the take-home messages: AKI is common in hospitalized children. AKI disease spectrum has potential to progress to AKD and CKD. That is chronic kidney disease. We have to be very careful. Watchful avoidance of nephrotoxic medications is useful. Early preventive approach in AKI is possible. So my purpose of the presentation is to make everyone understand that preventive approach in AKI is possible. Accelerated RRT may be needed in progressive AKI, and disease progression and improvement trajectory guides the treatment pathway. Thank you.
Thank you very much. It was very illustrative, simple and illustrative. The simple take-home message is monitor urine output for children who are acutely ill. That is the most important thing for anybody. Any questions? Next, we call upon Dr. Janani.
Dr. Janani ma'am will be speaking as part of the next session. On behalf of the organizing committee, we extend our heartfelt thanks for your time, effort, and generosity in sharing your knowledge. We request Nalini ma'am to present tokens of appreciation to Dr. Bala Ramachandran and Dr. Sasidharan. Thank you, ma'am. We now request Bala Ramachandran sir to present the memento to our chairperson, Nalini ma'am. We express our sincere thanks to our chairperson and speakers of this session. Introducing the next session, we have our chairperson, Dr. N. Benjamin Sagayaraj, Professor of Pediatrics with over 12 years of experience and multiple publications in national and international journals, to proceed over the next session. We invite you onto the stage, sir. We invite the first speaker, Dr. Janani Shankar ma'am.
Very good morning. I'd like to welcome Dr. Janani Shankar for the first talk of today's session, the pews.
Thanks, Benjamin. Good morning, everyone. At the outset, I thank the organizing committee of KONGU PEDICON for giving this opportunity. So my topic is pew score and beyond. So pew score, or pediatric early warning score, the Brighton Pews or the Monaghan Pew score, was developed at Brighton's Children's Hospital in the United Kingdom. It's a very useful tool which is used in a pediatric ER or a very busy OP setting, especially in a government hospital or a tertiary care hospital which is very busy, or even practitioners who have a very busy pediatric OPD where patients are waiting. It's used to identify children at risk for clinical deterioration. You know that the dengue season is coming and you have patients sitting with early shock amidst the patients who are waiting for immunization. A well child who's sitting waiting for an immunization, a child with a fever of 1 day, a child with a cough, along with a child who's in hypotensive shock or an early shock which requires immediate intervention. This is a scenario that we are all familiar with. It helps deciding subsequent intervention, and it also guides us on escalation of care, and higher the score, higher the risk of PICU transfer and mortality. So the components of pew score, if you see a very simple one, it has 3 components: the behavior, the respiratory system examination, and the cardiovascular system examination. So these are the 3 scores. Is this the pointer? Yeah. If you look at the cardiovascular, you have 0, 1, 2, 3. So 0 is normal, 1 is capillary refill of 3 seconds, 2 is capillary refill more than around 4 seconds and tachycardia, and 3 is a prolonged capillary refill of more than 5 seconds and tachycardia, which is disproportionate. Again, respiratory, normal respiratory efforts, breathing in room air, no hypoxia. 1 is more than mild contractions or requiring minimal oxygen. 2 is moderate contractions, more hypoxic. And 3 is severe contractions, grunting and very hypoxic. Behavior, again, a child who's very well interacting, playing is 0. Irritable but consolable is 1. Irritable, inconsolable, restless or pain, has severe pain becomes 2. And 3 is lethargic or confused. So you classify them as, in the respiratory, you classify them as mild, moderate and severe. So this is a very simple tool which you can train all your nurses or even non-medical professionals, your receptionists can be trained to do this quick assessment when the patients come and enroll themselves or register themselves in a busy pediatric outpatient department. So score 0 to 2, you can just tell them that your child is well, you can go to the outpatient. If they just, based on panic, they came off to the emergency room, you can just tell them your child is stable, you can go to the OP or you can wait for the doctors to come. 3 to 4, you make sure that the child is observed and you plan the further care. 5 and 6 require immediate care. So additional score 2 is for nebulization or persistent vomiting post-surgery. So you'll have to add a score of 2 if the child requires nebulization or if the child comes to you post-surgery with vomiting because you're suspecting a complication of the surgery. A total score obtained and the color code determines the severity of illness. So green is okay, yellow is safe, and orange and red requires immediate intervention. So the same scoring is continued and reassess as a reassessment tool. It's used when the patient is being monitored. The advantages are it's easy and quick to apply, simple to score and interpret, as I mentioned, can be done even by paramedics. I would go to a further step, even can be done by a non-medical person. Identify trends in improvement or deterioration. If you do the scoring at the onset, if you had a score of 4 or 5, you gave a nebulization or you gave some fluids, you gave some oxygen, the score from 5 came to 0, you know that the child is improving. And early recognition and timely intervention, improved quality of health services. You're really making your, whatever quality that you're delivering is made optimal. So these are some studies where they have done the use of pediatric early warning score and predicting diagnosis. So really these systematic review and meta-analysis said that Pew's score definitely helps in triaging these sick children and making the management optimal. So we'll move on to some case scenarios. A 5-month-old infant presented to the outpatient department with a history of red swelling over the vulval area noticed since 2 weeks of age, gradually increasing in size, otherwise very well, playful. There is a bright red non-tender skin lesion on the right labia majora, hemodynamically stable. So this child comes to the OP and the triaging is done. So if you look at the scoring, this child, all the 3 parameters falls into 0. Cardiovascular system stable, respiratory system is normal, child is playing and interacting very well with the nurse or the paramedic. So this child has a very low risk OP-based management. So vitals and reassess Q4-thali and continue current plan of care, refer the child to the outpatient department. This probably had a hemangioma from birth at the vulval area for which they came for a regular second opinion. Coming to the next case, 8-month-old female infant admitted in the ward with concerns of fever and poor feeding for 2 days. Initial Pew score was less than 2. On day 2 of illness, she had abnormal eye movements and reduced responsiveness, which lasted for 5 to 6 minutes. Pain responsive, no focal neurological deficit. You can see the child. Can you see those roving movements of the eyeball? So this child, if you see, the initial Pew score was 2. And then this happens. So this is the importance of periodic reassessment or application of the score again and again. So this child, if you look at the scoring, The child had a cardiovascular system, capillary refill for 3 seconds. There were no retractions, but the child was lethargic or confused, reduced response to voice or pain. So the score becomes 3 to 4. So 3 to 4, as we all see, it's borderline. You'll have to, these children require monitoring. So repeat Pew score in 60 minutes, vitals Q2 hourly, ensure that the pediatrician sees the child. Probably you should involve a pediatric neurologist, and plan of care may change based on the progression of the score. Coming to the case scenario 3, 1.5-year-old male child was taken to a nearby clinic with fever, cough, and coryza, and also had noisy breathing and voice change, referred to the hospital for further management. So this is the child. There is a mild stridor. I'm not sure whether you're all able to hear. So febrile to touch, has a mild inspiratory stridor and increased efforts of breathing. So what is the scoring? So cardiovascular is okay, 1. Respiratory system has moderate contractions and has, up to 4 liters a child is requiring, and playing appropriate, and you saw the child is nicely interacting and playing around, but has a mild respiratory distress and a stridor. So Pew score is 3, again moderate risk, needs observation at least in the holding area or the emergency room after a probable dexamethasone or your adrenaline nebulization. So you can always keep these children in the ER, periodically repeat the Pew score. If the Pew score comes to 0 to 1, you can even send them home. Now, coming to the next case scenario, 6-year-old girl, fever, vomiting for 5 days. Of course, they all walk in with a blood report these days. Dengue IgM is positive. So you can see the capillary refill is prolonged and there is a tachycardia. And the blood pressure for a 6-year-old is 104/67. That is probably hypotension. So you look at the scoring. 2, cardiovascular system, profound tachycardia, compensated shock. Respiratory system, there's tachypnea, minimal retractions. There is no hypoxia, and the child is irritable and inconsolable. So the score becomes 5. So here the child cannot be sent away. The child has to be shifted to the crash cart, and you have to start fluids. Probably, I think Sati and Sashidhar gave a nice talk on fluids. So fluids, you'll have to give dengue. You know this is a child with dengue. Based on the hematocrit, you decide. Compensated shock, you'll have to give a bolus of probably 10 ml per kg. Child reassessed after an hour, hemodynamics improved, fluid titrated, and admitted in HTU for further monitoring. Again, you repeat the score and periodically monitor the blood pressure and the capillary refill and also the PCV, and decide about further fluids. Coming to the next case scenario, 7-year-old male, known wheezer on reliever therapy, came with cough for 2 days, difficulty in breathing for a day. So this child, he's alert, he's anxious, flaring of ala nasi, moderate retractions, subcostal, intercostal. I'm sure he may be having an audible wheeze also. What is the score? So there is tachycardia, 20 above normal rate. There is marked tachypnea, accessory muscle use, hypoxia. He is lethargic. So Pew score is 6+. He needs immediate intervention. He requires oxygen, continuous nebulization with salbutamol, intravenous hydrocortisone, and he may require some more drugs like Magself or probably continuous nebulization with salbutamol. And these children, if effectively managed in the ER, you can prevent them from going into the PICU. And of course, your care doesn't end there. You'll have to give them a proper control management, prescribe a metered dose inhaler, and make sure they understand preventer-controller difference, because many of them, we see that they use the reliever regularly and use the controller SOS. There is a confusion. As pediatricians, I think we should spend some more time in explaining them what is a reliever and what is a controller, and make sure that they use it properly, because the technique really requires monitoring and supervision, because the technique goes wrong, they may not do well. It's coming to the fallacies. It can falsely overestimate the severity of illness because drugs play a role. The child may have received midazolam outside, comes to you after a febrile seizure, given a midazolam or a lorazepam outside. Children who are on beta blockers, the cardiac patients who are already on beta blockers, fever again is a confounding factor. Agitation, anxiety, even the thought that the child is brought to the hospital, or the sight of a nurse or a stethoscope or a doctor makes them very anxious. So you'll have tachycardia because of anxiety. So underlying physiological derangement cannot be explained. So what are the scores that are beyond PUS? You have the emergency triage assessment and treatment, the pediatric assessment triangle, the PRISM score and the Apache score, but these are all scores that are used after you do the PUS score. You do the PUS score, you assess, you triage them, green, yellow, orange and red, and decide your management based on which color code they belong to. Don't stop with that, keep doing a reassessment, and then comes to your PAT and PRISM and Apache, which are all applicable in the PICU setting. So this is the ETAT, and this is the pediatric assessment triangle, which we are all familiar. I think we apply this for every child who comes to the emergency, and in the crash cart, this is done by all the residents, and thanks to the knowledge that has been imparted to us by senior teachers like Dr. Nalini Madam and Dr. Lalita Janakiraman, who's here among the audience. Thanks to them who taught us PALS and made us understand what are the basics and how do you assess the child. Thank you. Wish you all a happy Independence Day.
Thank you for that insightful lecture, ma'am.
Sorry. Thank you, Dr. Janani, for a systematic presentation and making it easy for us to understand, and nice videos for people to get to know easily. Now, as our other second speaker is slightly delayed a bit, we will be moving on to the next topic. Maybe the next time Dr. Sujitra Ranjit will be speaking in another half an hour or so. Now we're going to have a topic on pediatric obesity, current management by Dr. Hakila. Over to you, madam.
Good morning, ladies and gentlemen. Wonderful organization, and kudos to the organizing committee of KONGU PEDICON. We wish you all the best, and also to carry on the same on to your national PEDICON. Best wishes to all the team, and thank you so much for the kind invite. So I'm actually a stopgap measure, which is a bit difficult to follow after Janani. Yeah, so I think we will not go on to regular obesity management. This is just a curtain raiser on awareness of what are the newer options that are available in the management of obesity in children. Times are gone where you always thought obesity was only because of poor lifestyle. You also have to understand there are a bit of genetics, environmental factors, and others that play a role. And you can't always blame people, but sometimes you should also remember certain things. When you are pampering your child, a child who's obese by 3 is going to be obese as an adolescent and an adult. There is 80% chance of that child sustaining obesity into adulthood. The same holds good for your cardiometabolic disorders. Once you're obese at 3 and you've started, you should remember a salt does not deposit on a pipe which carries water and close the pipe in one day or 2 days. It takes 5 or 6 years. The same holds good for your coronaries. Your fat can start depositing in your coronaries from the age of 2 years. So you're not as free as you think. The childhood chubbiness is not something to celebrate. It is a forerunner of ominous things to come. I think we will go from the IAP growth charts, which I would think, or which I firmly assume are the most important part of management of any childhood disorders. So this is the childhood obesity charts devised by Dr. Vaman Kadilkar and his team on behalf of IAP. So they've got color-coded lines. The orange lines is equivalent to the 25 equivalent. In adult, you say 25 and more is overweight, and more than 30 BMI is obese. But please remember, in India, as South Asian populations, we are at higher risk for metabolic disorders at lower weight and lower BMI. We are a cursed population because we always starved and now we are overeating. So this orange line is equivalent to the 23 BMI of an adult, and the red is a 27 equivalent of a BMI of an adult. So these are red lines and orange lines, which gives an ominous marker, like how Dr. Janani talked about marking and looking at it and then acting. So this has made it even more friendly. This is pediatrician friendly IAP growth charts, where you have a small table at the top end. You just have to look at the height and the weight, and it will automatically tell you which marking you are in. Are you more than the orange or are you beyond the red? So why are we talking about fat? It is not just eating. You also should remember there is huge number of hormones, and now fat tissues or adipose tissues assumed to be an endocrine organ on its own. What is definition of obesity? It actually, BMI is just a crude marker of obesity. Anybody whose weight is creating a problem for their health, they are obese. It doesn't have to be more than 60 BMI or 85 or 95. They are just crude markers. It gives you a mark or a bit of help to assess obesity. A condition of excessive fat accumulation that impairs health. More than or equal to 85 BMI for age and sex is overweight, and more than or equal to 95th percentile is obese. Why are we saying BMI is a crude marker? You will think of Serena Williams. She's a hugely well-built person. Her BMI will be high, but she's built with muscle. So you should remember fat is just weight and BMI are just crude markers of obesity. They are not the absolute authority on talking about difficulties you would face as an obese person. What is obesity? Exaggeration of normal adiposity, and why is it important? It puts you at risk for development of type 2 diabetes, dyslipidemia, hypertension, atherosclerosis, cardiac disease, stroke, and cancer. The international classification of adult obesity by the WHO is 24.9 and below are normal, 25 to 29.9 is overweight, class 1 obesity is low risk, 30 to 34.5, 35 to 39.9 is class 2 obesity, which is moderate risk, and more than 40 is class 3. But if you look at BMI of South Asians, that is particularly focusing on Indians, by the WHO, up to 22.9 is normal, 23 to 24.9. Even beyond 25, you are at higher risk for complications. It is low risk obesity, 25 to 29.9 is moderate risk or class 1 obesity, and more than 30 is class 2 obesity. These are the new BMI charts, extended BMI charts devised by IAP. Look at the lines. So you have an adult equivalent as an orange line. For more than 23 adult equivalent, more than 27 adult equivalent is red, which is obese. Class 2 obesity is 120 to 140% more than the assumed BMI for age and sex, and more than 140% is class 3 obesity, and they have to be intervened, and you have to intervene at this point. So these are the extended BMI charts for boys. This is a classic example of why South Asians are at risk for cardiometabolic disorders. There's one of our pioneer researchers on body proportions and metabolism in children, that is Dr. Chitranjan Yajnik, who's sitting with his colleague who's a white. Both of them have the same BMI of 22.3, but the amount of fat, particularly the visceral fat, was huge in Dr. Yajnik, in spite of him being of the similar BMI as his colleague who had much better metabolic profile. So that is why we talk about waist circumference charts. BMI is a crude marker. You have to add on points with different markers to look at adverse outcomes in later life. You are trying, prevention is better than cure. Varumun kapom. So we are looking at preventive steps to prevent onset of complications. So anything more than 70th centile for waist circumference for that particular age and sex is supposed to be a marker of an adverse metabolic profile. So obesity can cause, by inflammation and insulin resistance, can cause type 2 diabetes, systemic hypertension, atherosclerosis, non-alcoholic fatty liver disease, which is called MASLD now, and dyslipidemia. So why is metabolic syndrome in children and adolescents an important marker to look for? It's a clustering of metabolic risk factors for type 2 diabetes and cardiovascular diseases. This is defined by the IDF, the International Diabetes Federation, and Dr. Zimmet was the lead author. And please remember, Zimmet was somebody who said, this is one generation which will see their children die in front of them because of the adverse metabolic profile they develop by obesity, and that is such a heartbreaking statement which anybody can look at. Abdominal adiposity, diagnosed type 2 diabetes or a fasting glucose of more than 100, triglycerides of more than 150, reduced HDL of less than 40, and raised systolic blood pressure of more than 130, or a diastolic of more than 85. These are all putting you at high risk for cardiovascular diseases. We do a lot of investigations, which I will let go for now. So who would have an OGTT and when? As per the American Diabetes Association recommendations, from the age of 10 years, for every 3 years, a child who has more than 95th centile and who is obese will need an OGTT, and overweight of more than 85th centile will also need, with at least 2 risk factors, a positive family history, GDM in the mother, signs of insulin resistance like acanthosis nigricans, high risk race, which I think all of us fall into as South Asians or ethnicity. So pre-diabetes, HbA1c of 5.7 to 6.4, when you cross 6.5, you are a diabetic. A fasting sugar of 100 to 125 is pre, and more than 126, you are a diabetes. More than 200 with polyuria, polyphagia, and weight loss is diagnostic of diabetes. In OGTT, you might have to repeat it twice to confirm the diagnosis. This is one of our boys who had a cardiac disease. He had multiple valvular disease. He was put on high dose steroids for rheumatic heart disease. He put on so much of weight, he could not exercise. In this child, you can't blame him. You have to look for other options to treat him and make him better. He was very dedicated and he lost his weight only with diet control, but it is not always possible for everyone. So we also look at the lateral hypothalamic nucleus and the ventromedial nuclei of the hypothalamus, which are important for both satiety and appetite, and so most of the drugs are now targeting the hypothalamic centers. The next center which is targeted is your stomach, and the hormones like ghrelin, which increase your hunger, and satiety hormones like GLP-1. These are the targets for the newer therapies. So this is primary morbid obesity, and what are the other management options? Gastric balloons, yes, you can still try. Please remember, there is nothing like you don't have side effect with any drug, but the side effects are far and few and you can still try. But gastric balloons are not for children under the age of 18, and bariatric surgery again has been confirmed as a mode of therapy only beyond 18 years of age. There are other drugs including orlistat, lorcaserin, and phentermine topiramate, but they don't have too much of outcome or improvement in their outcomes. So GLP-1 analog is the new kid on the block, semaglutide. It was available as a tablet of 3, 7, and 14 milligrams in India, but it does not help in weight loss. It helps in improving your blood sugars and your cardiac parameters. But now we've got Wegovy, which has come into India, and the full all spectrum is available from 0.25, 0.5, 1, 1.7, and 2.4. So that is the full, but you have to remember, even then you have to go on a reduced calorie diet and increase physical activity to improve your outcomes. It is not without side effects. It increases insulin secretion. It slows gastric emptying. So you have a sense of fullness for a longer period of time, and so you don't feel hungry early. And it works on the GLP-1 receptors in the hypothalamus and reduces appetite and food cravings. It suppresses glucagon, which reduces the glucose production. But remember, the side effects can be cholelithiasis. You have to stop GLP-1 analog a week before any surgery because you have slow gastric emptying, you can have regurgitation and the patient can arrest on the table, or in the post-operative period. You can have increased pancreatic enzymes, so lipase and amylase have to be kept to watch on, acute renal injury, dyspepsia, retinal disorders. There have been reports of sudden blindness on people on semaglutide internationally. I haven't faced one yet. And any patient with a MEN2 mutation are at a risk for a medullary cell carcinoma of the thyroid, so you have to ask for histories of cancers in the family. Terzepatide is the next drug, which is Mounjaro. It is not available in the full spectrum of dosing. It again works more on the GIP rather than the GLP-1. They have a cumulative effect and they have an additional effect on both pathways. GIP increases insulin secretion from beta cells, increases beta cell survival and proliferation, and enhances insulin synthesis. It also works on the GLP-1 and reduces appetite and food intake, delays gastric emptying, and also helps in weight loss. And huge doses, they now say when you use it in a judicious manner, you can get outcomes as good as bariatric surgery. Bariatric surgery has to be recommended only in children after a multidisciplinary team evaluation. Remember, they have to have morbid obesity with at least 2 comorbidities, which is limiting their lifespan, with a post-pubertal BMI of more than or equal to 40 kg per meter squared, or more than 35 kg per meter squared, or its equivalents. long-term obesity and physiological maturity of more than or equal to Tanner stage 4, but now they say if they have a limitation of their lifespan, it can be recommended even beyond 12 years of age. You have to look at the risk-benefit analysis, assess the short-term and long-term risks of not operating versus risk associated with surgery. And remember, you also have a huge amounts of side effects post-surgery, particularly in Roux-en-Y, which gives the maximum weight loss. They have to be fit for anesthesia and surgery. You will try diet, exercise, and lifestyle modification for a year before you recommend surgery. There has to be a huge amount of commitment by the adolescent and family. So we always ask them to lose at least 5% of weight, which shows their commitment to follow up. And then that also halves the risk during anesthesia when you lose 5% of your weight. And it has to be done on a case-by-case evaluation. It is gastric banding or Roux-en-Y gastric bypass or laparoscopic sleeve gastrectomy, out of which I prefer sleeve gastrectomy because it preserves the pylorus and prevents dumping syndrome, which is hugely difficult for families to face. This is, I think, a classic picture all of you would have looked at. This is congenital leptin deficiency, and when you replace leptin, they became better. This is hypothalamic obesity with a suspected PCSK1 mutation. This is 65 kgs in a 3-year-old child. So there is a new drug on the block called MC4R agonist called setmelanotide, which is useful in obesity due to POMC, PCSK1, and leptin receptor deficiency. But this is one of my heroes who actually managed to lose his weight only with exercise and diet. He had gynecomastia and he has a tendency for keloid, so we could not suggest surgery for his gynecomastia. He started building up his body and became fine on his own only with diet and exercise. So ultimately, the pillar of support will still continue to be diet and exercise, but the other modalities continue to be helpful. Please remember, there will be families which will come and say, which I regularly face, a 16-year-old with 165 kgs, and the mom says, my child does not eat, which I think all of us face in our clinic. We will have to get past this to offer solutions. Thank you so much.
Thank you, Doctor. Thank you, Dr. Akila, for enumerating the different causes for obesity and the management of obesity. If you have any questions for the speakers, both Dr. Janani as well as for Dr. Akila, you're most welcome.
We remind delegates that they are invited to post their questions for the speakers through the Q&A link shared on the KONGU PEDICON WhatsApp group. Speakers will also be responding to these queries on the same platform. Are there any questions currently on the floor? On behalf of the organizing committee, we extend our heartfelt thanks to our speakers and our chairman. We kindly request you to accept a mark of our deep appreciation via mementos. We request our chairperson, Dr. Benjamin Sir, to kindly present our speakers, Janani ma'am and Ahila ma'am, with mementos. We now request Janani ma'am to kindly present our chairperson with a memento. Thank you all. Introducing the next session, we have our chairperson, Dr. Ruchira Gupta, Senior Consultant and National Joint Secretary Liaison of the IAP, to the stage. We are deeply honored to have you, ma'am. Welcome, ma'am. We invite the first speaker, Emergency Consultant Dr. Suchitra Ranjit, who is going to be speaking on interventions to improve outcomes in severe dengue. We invite you onto the stage, ma'am.
Thank you very much to the organizing committee, Dr. Rajendran, Dr. Shashi Kumar, and the entire very efficient team. So I'm delighted to be here Coimbatore has a culture of high work ethic. It's called the Manchester of the East, and medical care and healthcare is no exception. So yes, and I'm going to be speaking on severe dengue in the ICU, interventions that may improve outcome. So this talk is based on 3 of our papers that came out from our unit from the pediatric ICU in Apollo Children's Hospital. And mostly from the first one, which is targeted interventions that may improve outcome. Then a very controversial topic, hyperferritinemia in severe dengue. And then a review paper in the Pediatric Critical Care Medicine, which is the international journal of our specialty, Pediatric Critical Care Medicine. So it was a review paper about over 10 years ago. So these are the 10 points. How do we give fluid? How do we recognize and address compartment syndromes? How about blood products, the lethal triad? What do we do in fluid refractory shock? When do we consider invasive lines, respiratory support? And if we are intubating, how do we minimize the downsides and peri-intubation arrests, renal replacement, and finally on hyperferritinemia? So all of you have treated children with dengue, and I'm sure you're aware that there's a very slippery slope. So initially they get better and very quickly they go into fluid overload. And the best way is to minimize features of fluid overload is to aim for a low normal blood pressure. So we don't need to fill them up fully. We just need to fill them up so that the blood pressure is low normal. The urine output is just even low normal or even below, just 0.8 to 1 ml per kg per hour. So we need to measure it every hour. So you can see here that this child is in shock, right? The capillary refill is delayed. The liver is enlarged. His face looks edematous. Lungs are wet. So it's very tricky to resuscitate, give more fluid when they look as if they're already fluid overloaded. So the low-tech CVP equivalence, this was one way that we reported from our unit many years back, that blood pressure can be maintained, hematocrit will be high, and then we really don't know the baseline, so it's hard to say. Echo is not very reliable, IVC is not reliable, so urine output, if measured every hour, it's a low-tech, cheap, easily available device that you can do anywhere in any part of India or the world, and it gives you an indicator of both hypovolemia, that they are in shock, and hypervolemia. So because the kidneys get the second largest amount of blood flow in the body, so the kidneys are making urine, that means the circulating volume is good. If the kidneys are not making urine, circulating volume may not be good. Of course, there are caveats. If the child has already gone into renal failure, diuretic like Lasix given, or hyperglycemia, the urine output may be high or low, irrespective of the vascular status. So, and even though 1 to 2 ml per kg per hour is supposed to be the normal urine output, the moment the urine output starts going towards 2 ml per kg per hour, we need to remember to back down on the fluids. And the other, I think many of you all are aware that considering colloid is very early, even after 20 to 30 ml per kg of crystalloid, think of colloid really early down the track, especially if the child is needing ICU and urine output's not improving. Consider colloid really early, and in most children that colloid will help. In a few it may cause detriment and increase compartment issues. I'll discuss this later. So it's hard to predict whom it will help and whom it will hurt, and careful monitoring is the best way to figure it out. And what do we monitor? So the easiest, as I said, immediately you'll see some urine output improving, immediately in the next hour. And when the urine output improves, you are dialing down the fluid rates. And then the narrow pulse pressure becomes wide, the hematocrit decreases, and all this should happen without worsening of the respiratory status. That's the best possible scenario. Not all children may have this kind of scenario, but most of it will be there. So we could show that early use of colloids led to less of a positive fluid balance, and that has big impact not only on the need for ventilation, respiratory status, but also edema everywhere, which can be almost malignant. So very tight abdomen can cause a lot of downsides. I'm going to come to that in a moment. So which colloid are we going to use? These two are the most influential ladies internationally who have done a lot of work on dengue. Lucy Lum is a professor from Malaysia who's the author of the WHO guidelines on clinical management of dengue. Bridget Wills has actually come to Vietnam, has gone to Vietnam and done a lot of work which has actually been published in New England Journal of Medicine. So they advocate that even synthetic colloids like starch, synthetic starch, may be very cheap and effective. So those of you all who've been keeping pace with adult literature will know that synthetic colloids have got a really bad reputation in adults. So bad that the company is almost wanting to shut down production internationally. But these ladies argue that children do not have the adult pre-morbid conditions, chronic morbidities such as diabetes, renal failure, vascular disease, and provided we are very careful with the volumes used, like 20 to 30 ml per kg per day, synthetic colloids can be a hero in your unit. They can save lives and yet not make the family shell out thousands of rupees compared to albumin. Compartment syndrome. So generally when a patient responds to fluid and then urine output decreases, we tend to increase the fluid rate again, because the urine output is coming down, increase the fluid rate. So your options are, in these two children, can you make out what is happening? One is 10 months old and the other is 10 years old. Can you make out they're almost bursting, right? Face, chest, abdomen, everything is bursting. So what is happening with this child? So he's really concerned. The child is going back into shock because compartment syndromes are developing. And which is the most important compartment to consider here? Which is the most important compartment? The abdomen, right? It's like a woman who's pregnant on the verge of giving, and she's got triplets. So everything, that weight of fluid, the enlarged liver, all organs are just pressing on the blood vessels, the aorta, the mesenteric vessels, the IVC, so the kidneys, liver, nothing is getting good circulation, plus the whole diaphragm is being pressed up. So there's respiratory compromise, severe hypoxemia, no urine output, shock, acidosis. You can throw all epi, nor-epi at them, they're just not going to get better. So it seems simple, right? If the pressure is high, just decompress. But actually it's not so simple. What can happen when we decompress the abdomen? What can happen? So they can bleed and bleed and bleed and bleed and bleed, and they can die in front of you just bleeding. So the trick is to do it really carefully. So we need to have a very controlled. I remember Janani, when we used to struggle with children and in child's trust with these tight abdomens. And then I remember putting in a PD catheter, and the fluid from the abdomen was spurting like a jet. At the same time, urine output also started coming out. The child was anuric for many hours. So that was a clear lesson that, I mean, you know, decompressing the abdomen can help many organs, but later down 4, 6 hours later, we're thinking, oh, this child is fine, and we walked out, and later they can start bleeding. So we need to always have a very controlled rate of drainage. Even the placement should be under ultrasound guidance. So, it's a very controlled drainage. It's very tempting to let all of that fluid come out in an hour or so, but like about 3 to 5 ml per kg per hour. It's a very, very controlled drainage, and co-administration of albumin will help recurrence of shock, will help the onset of bleeding. Invasive lines, we have to be really smart about this, right? Generally, intensivists are the main culprits here. Generally, when a child is in shock, not getting better in 1 or 2 hours, we are in a hurry to put in lines, central line, arterial line, etc. We need to be smart. So generally, central lines must be earned, and peripheral lines, provided they're nice blue or pink lines and flowing well, they can do a good job for 24, 36, 48 hours in the majority. We need to remember to avoid nasal tubes, nasogastric tubes, because most children have enlarged adenoids, tonsils, and just even if it's a lubricated tube, it can cause a lot of bleeding. So if we are putting in a central line, if we must, then femoral access is better than neck, and radial lines electively after fluid resuscitation. So as we know, there's a big risk of bleeding. So hemostasis, so if a child we had a child who came from Port Blair, needed intubation in the airport, and the whole, a fellow and some nurses went. As soon as a fellow intubated, the nurse put the NG tube, and then the child came to us, was bleeding, bleeding, bleeding. But initially it looked as if all that blood from the adenoids trickled via the tracheal tube to the lung, then into the stomach and came back as melena. And then, so it looked as if he's gone into DIC. So only after a while we figured out that, it was actually the enlarged, and once it was packed, so ENT surgeon just did a Foley catheter on the nose, inflated the cuff, pulled it out, and that acted as a nice tampon. Exact same situation in dengue. So you have a patient with hypothermia, no amount of bleeding, no amount of factors can control the bleeding. Even factor 7 may not work if there's likewise with acidosis. So monitor the core temperatures with great care, and then correct it, aim for a temperature at least over 36. So we know that even exsanguinating hemorrhage can be occult, and then the hemoglobin may be normal, because initially it's high, 36, 40, 45, 50, and when they bleed, it just comes down to 45, 40, and high 30s. We won't even think this child is bleeding. So how do we suspect that the patient may have hemorrhagic shock that's contributing to hypovolemic shock? So if you find that the acidosis, lactate, tachycardia is much more profound than the degree of hemoconcentration, the shock itself is very profound, a lot of tachycardia. So, and in case you're friends with your blood bank, make friends, take them out for coffee, because when you need blood products, whole blood is magic, it's sheer magic, because it's whole fresh blood. So a family member, a little distant, who's maybe previously screened and donated, and you infuse within 6 hours of collection, it can address all of the bleeding problems, and it acts like magic. So just one half in the morning and half in the evening, that's what we do when they're bleeding a lot. And many children, such cheap interventions, but modern blood banks don't believe in whole blood products because that's their mantra, right? One product can serve 3 patients. So it was very hard for us to convince our blood bank chief, but finally it's not bad. Fluid refractory shock, you can have many reasons of fluid refractory shock, including myocardial dysfunction. And remember that if you're giving inotropes, 6 to 8 hours should be the limit, because inotropes itself, it's just like they have edema everywhere, even the heart is swollen and edematous. And inotropes in a swollen heart, there's not much internal cavity. It's all edematous, and it can easily go into diastolic dysfunction whenever any inotrope causes tachycardia. And it typically worsens as worsening shock and pulmonary edema as the catecholamine doses are increased. I can't see my time. Yeah. Okay. One more minute. Okay. Oh, thank you. I think I'll be done. So respiratory support. So this is hypovolemic shock. Children, right? Children with dengue shock have less circulating volume. So circulating volume needs that negative intrathoracic pressure. When you and I breathe, we are generating a negative intrathoracic pressure that sucks in the venous return. So in this kind of patient, when we do positive pressure, the patient can have precipitous hypotension and even a cardiac arrest. So it's not a good deal. That decision must not be made easily. And as far as possible, aim for non-invasive. So you're getting 2 in 1. You're giving a little bit of positive pressure and keeping those flooded alveoli open. At the same time, the child's spontaneous breathing is being preserved. And many children tolerate NIV surprisingly well. So this child looks, in fact, more unhappy after it was removed. In case intubation cannot be avoided, remember there's a high risk of peri-intubation arrest because they're shocked, their lungs are wiped out, they're acidotic, they can bleed. So it's a brave person who volunteers to intubate such people, because it's not nice. He'll say, Suchitra intubated and child died in 5 minutes. So it's a very not a nice reputation to have. Unfortunately, or fortunately, most of these bleeding patients, I was the one who intubated, and luckily, I don't think any child died immediately at least. So the whole terminology is no longer called rapid sequence intubation in such children. It's called resuscitation sequence intubation. In other words, that term rapid, we have to rush to put in a plastic tube, is out, right? When there's severe hypoxemia and shock. So correcting hypoxemia and performing resuscitation should precede intubation. In other words, you start your inotropes, give some high flow. That high flow can remain even as you're intubating, and all of these will simple maneuvers, but can really decrease the risk of peri-intubation arrest. So if many of them, once their hemodynamics are stable and you think the leaky phase has passed, many of them will need to be considered for fluid removal, and then your options are diuretics, peritoneal dialysis, CRRT, and SLED. Okay? So hybrid therapies may be performed. CRRT can cause significant hypothermia, and I've told you earlier that this itself can cause a lot of bleeding. Sustained SLED, intermittent hemodialysis that is stretched out over the day, less hypothermia, more hemodynamically stable, and far cheaper. So hyperferritinemia, does this always mean a macrophage activation syndrome? We published this paper about 3 years back, and we could show that 96% improved with supportive therapy alone, including 22% out of 24 with ferritin more than 10,000. So it was just a marker of severe disease, and it's just the child is telling you, this child needs a lot of care, careful monitoring, and don't put a child in a corner in a high dependency unit. So if the child has liver failure and high ferritin, then early plasma exchange may be useful. Similar paper in IJCCM from Child's Trust early this year again showed that immunomodulation was given for only about just over 10% when ferritin was over 10,000. But when do you actually consider immunomodulation? Certainly some children will require. So after the critical phase is over, if there's unremitting fever, persistent cytopenias, and organ failures. So this was one of our sickest child. She's a national badminton player. Required all of our ICU supports. But the nice thing about dengue is that all of them, when they come back to you, you hardly think that they're almost dying a month ago. Like the whole ICU is up trying to pull them back from heaven, but they come back completely well, going to school. So whatever efforts, sleepless nights is all completely worthwhile. And I thank you all for your patient listening.
Thank you, ma'am. Thank you, ma'am. That was quite the dynamic lecture.
Thank you, Dr. Suchitra, for amazing presentation and a very, very insightful talk. Especially dengue fever, when it comes, it does not give any warning. But here, with early detection and timely intervention and the fluid management can definitely bring a change. And the way you have narrated the simple parameters to monitor, especially urine output, which most of the time people forget, then this journey may become easier, and we can turn the risk of calamity to well child when we discharge the patient from ICU. So any questions from the audience? I know Madam has given such an amazing, very clear-cut presentation, which was self-explanatory, and you explained it well. But despite that also, if anyone is interested to ask any question, because dengue is one thing which is going to hit hard now. So I think, ma'am, you have done a great job.
We received one question, ma'am, regarding severe dengue. In case of severe hemorrhage, just explain about the tranexamic acid infusion, ma'am.
Yeah, I actually had it on the slide. So certainly giving a loading dose and then an infusion is certainly helpful. There's no argument about that at all. But that alone will not do the job. That's only one of the things that you do apart from hemostasis and blood products, etc.
Thank you, ma'am. I want to ask you, though it's not that much related, but then the children with severe dengue can sometimes develop edema kind of picture subsequently. Edema. So do you feel that a proper timely intervention with fluid management, does it has got any say in development of edema? Because I feel it is a secondary autoimmune kind of picture which happens subsequently. Not really. Thank you very much.
Thank you for sharing your experience, ma'am. I now invite pediatric endocrinologist from PGI Chandigarh, Dr. Rakesh Kumar sir, to present a guide for pediatricians on technology-enabled care in type 1 diabetes.
Good morning, everyone. At the outset, I thank organizers for inviting me here, and it's my pleasure to be here and bring greetings from Chandigarh. If I can correct my name here, there is no B in the name. It's Rakesh Kumar, and I come from North India. Okay. So before I actually jump onto technology for type 1 diabetes, I would like to clear the ground first, what's happening right now with regards to management of type 1 diabetes. I'm sure most of you would agree that type 1 diabetes incidence is actually quite steeply on the rise. Most of you, even if I talk about me, 25 years back when I did my MD, I saw only 2 patients of type 1 diabetes in my whole 3-year training. I was in a good tertiary care center where we had good number of patients though. Second thing is India is actually #1 in the world with regards to number of type 1 diabetes children and adolescents. That's another hard fact. Even type 2 India is at number 2. But in type 1, less than 20 years, India is at the top. So that's another fact. And the incidence has been actually rapidly increasing. Third fact is that nearly 70% of patients with type 1 diabetes have suboptimal glycemic control. So that's another important issue. And why so? Obviously, despite giving 4 injections of insulin or 4 insulin injections per day, 4 times checking glucometer, sugar with glucometer, still there are a lot of issues which are to be addressed, and maybe they are not humanly possible, in the sense that ideally all snacks and meals should be covered with bolus insulin, which is not really possible humanly. Similarly, we need to have more frequent blood sugar checks to keep track of our sugars before and after meals, which actually recommended frequency of checking blood sugar by glucometer is 6 to 10 times per day, which again, it's a difficult job. So that's where actually technology comes in and helps. Another important issue with diabetes, type 1 diabetes management, is that we have only one drug since the discovery of that drug 100 years back, 1922, when insulin was discovered, and nothing more has come up in those 100 years. That's another issue. So that's again, technology has come up for the rescue. So with these facts, I would now actually move on to my topic proper. So I have actually set that ground that why technology is important. So then I'll be briefly, in 15 minutes, try to give an overview of whatever technology is available for managing children with type 1 diabetes, insulin pumps, continuous glucose monitoring systems, and other forms of technology which are useful in caring these children. I usually compare the management of type 1 diabetes with this 4-legged table analogy. So the tabletop here has to be stable, means the glucose control, if we want it to be stable, we need to have these 4 legs of the table which are strong enough, and they have to be equally strong. So that's more important. So what are these 4 legs? It's insulin therapy, which we as physicians are more interested in whenever we see these children, to give optimal insulin regimen, which is obviously 4 or more injections per day. That's the optimal insulin regimen. Monitoring will include daily glucose checking, 3 monthly HbA1c, and hospital visits. Dietary plan, we are obviously not restricting particular diets, but it has to be planned. So whatever diet is to be taken, we have to titrate it with the insulin dose. And similarly, there has to be some exercise or activity plan to take care of the glucose during that activity. And this table is actually standing on firm grounding of diabetes self-management education and support. So that's the most important intervention if we have to think of. So this table cannot be standing or in the air, but it has to be on the firm ground of diabetes self-management education and support, where is the role of healthcare professionals. We need to have more and more type 1 diabetes specific educators to make these parents and children knowledgeable about managing their diabetes at home. So that's important. So why technology? It's now proven beyond doubt that use of technology, particularly the latest sensor-augmented insulin pump therapy, has improved glycemic control significantly. So in the West, where 70 to 80% of children or adolescents are using insulin pump, almost 70 to 80% of them are actually achieving the targets, or actually optimally controlled with regards to their glycemia. So they have HbA1c target less than 7, and time in range now is the new metric when continuous glucose monitoring systems are available. So they achieve that time in range of more than 70% in a day. So obviously there is a reduced hypoglycemia risk, personalized care is there, lifestyle flexibility is there, Then with use of these technology, data can be easily shared to the healthcare physicians, to their parents, caregivers of the child, so that intervention can be done in timely manner. Obviously, there is a reduced overall burden of number of decisions which are to be taken daily, extra decisions these children have to take to manage their diabetes on day-to-day basis. So obviously improved quality of life as well. So there is a long list of technology being used for type 1 diabetes. Obviously, I will not be able to cover most of them, but the ones in the green in the top are the most common and in fact FDA approved for use in type 1 diabetes. The continuous glucose monitoring system, flash glucose monitoring systems, insulin pumps, patch pump is another type of pump basically, and the latest ones called hybrid closed loop systems or automated insulin delivery systems. They are all approved for use in children with type 1 diabetes. So I'll be giving a brief overview of all these. So insulin pumps or continuous subcutaneous insulin infusion systems, they are different, come in obviously different shapes and sizes and types. Unfortunately, in India, we don't have that much choice. We only have one of them available, the one on the right from Medtronic called 780G insulin pump. That's the latest model, and it's an automated insulin delivery device. The patch pump, it's there in the white. It's a small and quite popular among adolescents, particularly because it doesn't have any tubings attached to it. It's just a patch attached to the arm, and it is use and throw. After 3 days, we can just remove it and another patch is attached. And handheld device is there to manage the glucose. This is how a normal pump would look like, an automated insulin pump delivery system would look like. On one side, we have glucose sensor and transmitter, which is continuously giving glucose value to the pump, and pump in turn through that tubing and cannula will infuse basal as well as bolus doses as and when required. What's good about the automated insulin systems is that they give multiple correction doses automatically. So whenever sugar is going high, the pump will give multiple small correction doses till that sugar comes down to the target which we have fixed, say around 110 or 100 or 120 as per the control we want. And it also adjusted basal doses on its own. So normally when we give glargine, the basal dose is fixed for 24 hours. We cannot increase or decrease it. But with the pump, it's possible that basal doses can be adjusted based on the glucose levels in the blood. And if sugars are coming down, basal doses are in fact shut off. So that's important. And similarly, if it is going up, basal doses will also be going, that rate will be going up. So that's how automated insulin delivery works. Obviously with the CGM, which is providing glucose continuously. So this is basically how the automated insulin delivery system works. It's a loop basically where the glucose is sensed by the sensor, information is given to the pump, algorithm in the pump gives instruction for the insulin to be delivered. So this is the whole loop which is being actually completed. So this is called closed loop system or automated insulin delivery system. So this is still hybrid at this stage because it's not like our natural pancreas. It's not giving or covering whole endogenous function of the pancreas in a normal body. So automated insulin delivery, when we call it fully automated, would be when it has both insulin as well as glucagon. Bionic, so-called bionic pancreas. So I'll be just coming to it. So over the years, the technology has obviously evolved, starting from basic pump, which was just a replacement for pricks to avoid multiple pricks through the MDI. The pump used to give more number of boluses or pricks in a day without actually pricking the child. So that was the initial intended use of pump, and over time when continuous glucose monitoring systems have come, and then the pumps compatible with CGM, we call them sensor augmented pump therapy, so which further improved. Then there were pumps which prevented hypoglycemia through low glucose suspend function. Then there was predictive low glucose suspend function. These are basically advancements in technology. And the latest 780G pump is called hybrid closed loop or automated insulin delivery system. And what we actually are longing for is the one on the top, the so-called artificial pancreas. which is also in trials, in fact. So obviously, insulin pumps are better than MDI. There is no denial on the fact. Say around 10 years back, there were a lot of issues in the sense that the pumps available at that time, they were not good enough and they were not making much difference in glycemic control. Although they were making life a bit easier for the children, but glycemic control was not that great. But with the latest pumps, there is significant improvement in HbA1c. So there is safety, quality of life is improved. All the standard scientific organizations, based on evidence, are recommending insulin pumps as the first choice of treatment for children with type 1 diabetes. Obviously, cost is the main issue. That's the main problem for our setup. Okay, for the sake of time. So this is the first hybrid closed loop which came up in 2019. In fact, it was approved in 2019 by FDA. It gave the basal doses automatically and delivered the correction boluses as well. So that's how the automated insulin delivery worked. This is still not available in India, unfortunately. And this is the one we have in India for last, say, around 3-4 years now. It was approved by FDA in 2023 and European Medical Agency in 2020. So this, as told already, gives both correction boluses as well as automated basal delivery. Only manual intervention required with this pump is that the patient has to inform the pump that I'm going to take carbs or I'm going to take a snack or meal or whatever. That's the only manual intervention required as of now. And ideally, we don't want even that. So we should be eating whatever we want and pump should take care of it. But yes, as of now, we still have to enter carbs before we take a meal or snack or whatever. That's the only intervention required. There is another closed loop system approved in Europe, obviously not available here as of now. Then further advanced automated insulin delivery system is islet bionic pancreas. It has, as of now, although it's called bionic, but it's not really bionic in the sense that it doesn't have glucagon infusion in it. So this is further advanced because here we don't need to enter the carbs as number of carbs. Rather, we can just give small, medium, or large meal is entered, and rest of it is taken care by the pump. And we just have to initially set weight of the child. We just enter weight of the child and rest, all the things are taken care by the pump. So it's slightly more advanced than what is already available. It was approved in 2023 again by FDA, but has not reached India as yet. This is what I was trying to talk about, the comparison between bionic pancreas and this islet, the latest advanced version available. So obviously we need insulin and glucagon because hypoglycemia is one of the major issues in these children. So that has to be taken care by the glucagon. Ideally, we shouldn't have any manual intervention required for fully automated insulin delivery. Complete pancreatic endocrine replacement has to be there with the bionic pancreas. Yes, it is still in clinical trials, and we hope soon that one of these will be approved. Coming to continuous glucose monitoring system, there are actually real-time ones. The implantable CGM is also available in the US, where subcutaneous sensor is placed subcutaneous and it lasts for 6 months. It has to be replaced after 6 months again. Then there is intermittently scanned CGM as well available. What is difference between SMBG and CGM? SMBG is self-monitoring of blood glucose. So SMBG is just giving us a photo, whereas CGM is giving us the whole video. So what is happening before and after that glucose value, that's more important for us. Trends are more important. Obviously, SMBG is more accurate and cheaper. And CGM can have other advantages like they can provide alarms when sugars are going high or low. We can download the report, share it with the physicians. The parents can actually, on an app, they can actually track glucose of the child when they are even away. These are the trend arrows. So normally with glucometer, we'll have only that 202 value, but no arrows or trends are available. So these arrows and trends are important. If arrow is going up, it means actual sugar is slightly higher in the sense that we have to treat for a slightly higher sugar. If arrow is going down, we have to treat for a slightly lower sugars. That's the most important use of these arrows. So this is how the CGM device actually looks like. It has a sensor, a transmitter, and a wireless monitor or handheld device where we can see the glucose values. So for the sake of time, I'll have to skip. So there are actually 3 different types of CGM available in India. The Libre Freestyle reader is most commonly and easily available. It's a standalone sensor in the sense that it's not, it's used without obviously pump. Medtronic along with the pump has CGMs available, and CGM can be used even without pump for Medtronic as well. So Dexcom is another one available, not readily, but it can be imported from abroad. So this is how it is applied. Implantable sensor from Eversense is available in US and approved 2 years back. This is how it would look like. The first one is the sensor, which is placed subcutaneously. The second one is the transmitter, which will transmit sugars to the app on the phone. This is how it would look like. So with CGM being available, now people are talking of time in range as the metric for monitoring glucose control in children with diabetes. So time in range is percentage of time where blood sugar of a child is between 70 to 180 in 24 hours. So the target is more than 70%. And more than 250 should be less than 5%, 180 to 250 should be less than 20% actually. And less than 70 to 54 would be around, target would be less than 4%, and less than 54 should be less than 1%. These are the targets. But most of the children on automated insulin deliveries will actually have very good time in range of anywhere from 85 to 95. Then technology, further use smart insulin pens are now available. The pens which are recording all the doses can be, and those doses as logbook can be seen in the phone apps as well. So this becomes a quite important data recording. Then there are data management platforms and applications available on the web. Tidepool, Gluco, Dexcom Clarity, Libre View, Libre Link, and Libre Connect are 3 apps for physicians, the parents, and the patient respectively. There are many such apps available. They are actually good to upload data from the glucometers, analyze them, generating reports, and that helps in decision making. This is one such Tidepool web which is freely available, and all the glucometers data, all available glucometers in India as well, they can be their data can be uploaded, insulin pumps data can be uploaded, and they can generate reports. Then there are clinical decision support systems available. There are some websites where the patient can actually ask for immediate action to whatever their glucose level is or action they want. So one DreamEd Pro is one such website available and commonly used in Europe for answering immediate queries. Bolus dose calculators are also available. There are many applications available. So one has to enter the glucose value, the carb value, the bolus dose, ISF, what is insulin sensitivity of the patient, and insulin carb ratio, the bolus can be calculated accordingly. Telemedicine, particularly after COVID, has obviously touched lives of our patients and us in many ways, and telemedicine in abroad has been very commonly used for, particularly for the follow-up consultations. This, I have quoted one study from in India only from SGPGI Lucknow. They have reported in Indian Pediatrics their experience of using telemedicine for follow-up of these children. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Rakesh, sir, for elaborate presentation on different type of insulin devices, the smart pens, insulin pumps, and the CGM and SGM, all monitoring assets which are available with us and making life of patients, especially our patient, those who belonging to pediatric and adolescent category. It's very difficult for them to accept the disease. And then on the top of that, treatment is equally painful as well as difficult to monitor the things and all. I'm sure with these devices which you have shown us, things will become much easier and much more manageable. So thank you very much for the detailed presentation. Any question from the audience? Neminathan sir, please.
I have a question to previous speaker, Dr. Sujitra madam. Thank you madam for the elaborate speech. Ma'am, your experience, we use HES in our center, high ethylene starch, in our center in dengue management, particularly when you use colloids. We found we had difficulties in blood grouping. What's your experience? And we had some children, we had 2 out of around 12 children, we had difficulty in grouping after the starch. And I want your experience about low dose furosemide infusion in children who develop ARDS following dengue.
So, firstly, I'm not sure whether I would call it ARDS, because most of the time it is fluid overload, a lot of pleural effusions, alveoli are full of fluid. So for ARDS, we have to rule out fluid overload as a cause. There is maybe some element of capillary leak and some alveoli disrupted, so they could be on the spectrum. But once that critical phase is over, when the patients require respiratory support, even if they are not on full high levels of ventilation, it's always a good idea to give a bit of Lasix infusion. And generally, it's a very, very low dose. We don't give a bolus. You start about 1 milligram per kg per day. So imagine how low it is. Normally, we give half to 1 milligram per kg per dose. So this is over the entire day. So it's just a trickle dose and titrate to the urine output. So some of them can have a very exuberant response and become almost polyuric. So we need to back off at that time. So it's just trial and error. There's no one dose that fits all children.
Any other questions from audience?
Thank you, ma'am. Together, this session
think we
truly
are done.
addressed the need of the hour, given the challenges we face today. We thank Dr. Ruchira Gupta and our speakers, Dr. Suchitra ma'am and Dr. Rakesh Kumar sir, for their thoughtful contributions which have added great value to KONGU PEDICON 2025. As a mark of our deep appreciation, we request you to accept mementos from our side. We request Ruchira ma'am to please present our speakers with a token of appreciation. We request Suchitra ma'am to kindly present our chairperson with a token of gratitude. Thank you all. We would once again like to remind our delegates about the Q&A link shared on the KONGU PEDICON WhatsApp group, where they can post questions to the speakers and receive responses for the same. We encourage your active participation to enrich the discussions. Introducing the next session for the day, It is my privilege to now invite the chairperson for the next session, Dr. Ramesh S., former medical superintendent and professor and head of the Department of Pediatrics at Raja Muttaya Medical College. We invite you onto the stage, sir. Welcome, sir.
Good afternoon, respected colleagues and fellow delegates. The next session is on sarcopenic obesity. We all heard Dr. Ahila Apau detailing about the magnitude of the problem of obesity and also the current concepts in management. Sarcopenic obesity is a combination of both muscle loss as well as increase in body fat. Essentially, it was a problem of adults and older people. Now it has crept into children. It's a deadly combination of dreaded complication of obesity. As the muscle mass decreases, the ability to burn calories decreases, leading to excess fat accumulation. Conversely, obesity leads to decreased mobility, and that leads to destruction in the muscle mass. So now we have an eminent speaker, senior gastroenterologist from Chennai, Dr. Bhaskar Raju, a star speaker among all pediatric conferences. Is known for his timely jokes and dialogues, punch dialogues. Over to you, sir.
Punch dialogues. I wish I had enough of them. Anyway, I'm extremely sorry. This sarcopenic obesity was the topic that was given to me earlier when I started associating myself with this conference, but over a period of time I was told somebody else is speaking on obesity, and then they added this childhood nutrition, which is a huge topic by itself. So I really didn't know which one to concentrate on. A few years ago, I met one of my very close medical friends who is a famous diabetologist in Chennai, and he was telling me that he is trying to conduct a study on adults from 30 to 50, follow them up and see what are all the factors that are making them obese. And I told him, you're missing the most important point. The most vital thing for obesity in adults is marriage. If you get married, within a year or two, your wife and mother-in-law will pump you so much food that no other girl will ever look at you. So that's why I decided, I thought I will talk about toddler nutrition, which is one area of nutrition which very few people actually talk about and very few people know much about. So this is beyond 1,000 days. Up to 1,000 days, all of you have heard about it. Nutrition vital for sustenance and growth. Also vital for sustenance and growth is physical activity and social interactions. I'm not spending much time on them because that's not the focus of my topic. Today, I will talk a little about carbohydrates in toddler nutrition, something about proteins in toddler nutrition, something about fats, and finally, a few micronutrients. There are like hundreds of micronutrients. I obviously cannot cover all of them. I'll just touch about 2 or 3 of them, which I believe are vital and will be useful for you. There are plenty of sugars available for the child to take. I'll spend a little time on lactose, because these are all just sugars. There's no major benefit for the child by taking any of these in significant quantities. Then there is oligosaccharides. I can talk the whole day about oligosaccharides. I'm not going there. It's a totally different topic by itself. And then we have digestible carbs and non-digestible fiber, insoluble fiber. These are all the components of carbohydrates an average toddler should take. What are the requirements? For an average 5 to 6 year old child, 1,500 to 2,000. But the point I want to make here is what all mothers make a mistake. Around 60 to 70% of calorie requirements in pediatric practice come from carbs, which is bad. What is recommended by most nutritionists, only 55% should actually, like one of my old friends who is no more a famous pediatrician in Chennai, say, you're a very lucky pediatrician if 55% of your income comes without tax. So it wasn't for me, it was somebody else. Then we have the good sugars, the bad sugars. The good sugars are the fruit sugars when they come in the form of fruit, not as fructose. If you take it as fructose, you are really in for trouble, because plain fructose has no insulin to control its entry into the cell, jumps into the cell, creates havoc inside. These are obviously the bad sugars which you know about. The best, I'll spend a few minutes on lactose, because this is something very few people talk about and very few people really understand. Lactose did not exist in the universe. I'm not even saying world, in the universe in the pre-mammalian era. Even now, other than mother's milk, other than mammalian milk, lactose doesn't exist in any other foodstuff. Why? Years ago, millions of years ago, there was a proto-mammalian called platypus. Many of you have visited New Zealand or Papua New Guinea or Australia would have seen that. That's the gap between birds and mammals. That was the one which synthesized lactose for the very first time in the universe through a random mutation. Imagine something as simple as a random mutation can dramatically change evolution over a period of time. A mutation of lactalbumin gene made the glycerol transferase capable of combining glucose and galactose. Prior to that, they could combine glucose with fructose, glucose with virtually anything else, but not galactose, and that resulted. So you can ask me the question, so what? What's the big deal? Thus, lactose became the primary energy source for the entire mammalian world. It created a unique lactobiome. All animals have, or all living beings have organisms within them except single-celled organisms. Even small tubular organisms will have organisms inside it. But the best microbiome you can get is a lactose-based microbiome called lactobiome. And lactose dramatically increased calcium absorption in mammals. For example, you see a hippopotamus and you see the bone, femur bone of the hippopotamus. Hippopotamus or a rhinoceros is similar to a mid-sized dinosaurus. A mid-sized dinosaurus will have a bone almost 10 times the size of a rhinoceros. A mid-sized dinosaur I'm talking about, which gives you a good idea how much the bones have become narrower and stronger and giving mammals the mobility which has resulted in mammals virtually taking over the entire world. Then comes the most important thing, galactose. Lactose is the only component which provides galactose to the human body. And as you go up the ascending order of IQ among animals, you'll usually find the glucose erythrocytes being slowly replaced by galactose erythrocytes. Human beings have the highest concentration of galactose erythrocytes, and the thanks goes to lactose. That means at least 2 glasses or cups of whole milk a day is a basis for good nutrition in toddlers. Complex carbohydrates, sources, of course you are all very familiar with it, brown rice, these are the ones which have good glycemic load in the sense they have a lot of carbohydrates in them, but low glycemic index because they do not dramatically increase glucose values in the body. But then, will children eat it? My granddaughter came from the US a few weeks ago, and my wife, being very health conscious, made this quinoa upma. That kid had 1 teaspoon of it, and the question she asked was, is this even human food? That's where the problem lies. It's very difficult to make children eat that. This is an excellent study which came from Bristol. They looked at the effect of breakfast on IQ and the kind of breakfast that results in a better IQ. They said, which I said just a minute ago, high glycemic load. It must be a carbohydrate loaded but low glycemic index. That really resulted. They followed children for almost up to 5 to 6 years, and they were able to show that those who took that kind of breakfast had better IQ. They are the ones who propagated only 55% of calories should come through carbs. I'll touch upon what else should come through, what else should provide the remaining carbs. Minimum 40% of a day's calorie requirements must come through a breakfast. Like they usually say, eat like an emperor breakfast, eat like a king lunch, and eat like a pauper dinner. Exactly the opposite of what I do. and I'm sure most of you as well. Complex carbs and minimal sugar. Dosage of fibers, I'm not spending any time on that. All of you are very familiar with it, but fibers are absolutely essential, and you all know the benefits. Just a few words on proteins, and in one particular protein which I need to emphasize on, basically because this is a sponsored talk, many of you might be aware, by a particular company, and if I don't mention their product, I don't get my airfare, I don't get my lunch, and I don't get my vodka. So, we have our class 1 proteins, class 2 proteins, all of you are very familiar with it. This is a famous study from Sulagna Bandopatya from Bangalore, where they studied protein intake of pregnant women and children in India. The surprise result, they studied almost about 2,000 to 3,000 children. The really surprising result, good. The protein intake in toddlers in India is relatively good compared to the period they found the protein intake was really bad was 6 months to 24 months. Beyond 24 months, apparently it improved. You can see here, except a few states like Rajasthan, Madhya Pradesh, Orissa, Bihar. Look at Tamil Nadu, really good, the protein intake, basically because of our midday meal scheme and morning breakfast which the government is providing for the children. But what is the downside to this whole story? The downside to the whole story is 88% of children took predominantly class 2 proteins. In fact, a few years ago, which was about 40th year of my marriage, we went for a honeymoon to Bombay soon after we got married in Dadar Express. And my wife said, we want to relive that experience. Let's go to Bombay and Dadar Express and have the 40th honeymoon there. And it definitely took us to Bombay. There's no doubt about that. But we arrived there absolutely exhausted, tired, stinking, and worst of all was constipated. So it's not, it does do the job, the class 2 proteins, but you cannot compare it with class 1 proteins, which is really good. So you can ask me the question, what is a cheap class 1 protein you can use in Indian toddlers so that the protein intake is good, and not only good, quality protein goes in. This is the study which studied whey protein. Whey permeate is whatever is left after cheese is removed from milk, ready to use supplementary food. You know about RUFs. They studied a variety of proteins. They studied soy protein, they studied whey protein, they studied peanut-based protein, other plant-based proteins. Now, I'm not surprised. Look at the recovery from SAM and as well as chronic nutrition, undernutrition. You can see here the best results are from whey-based protein. So you can ask me the question, what's the big deal? What's so great about whey which your plant-based or soy-based protein does not have? It has one particular chemical in it. I can ask you that question, what that chemical is. It's extremely simple. If I tell you what it is, you'll be saying, oh my God, is this what you're going to talk about? Yes, it is this I'm going to talk about. It is amino acid leucine. Amino acid leucine has excellent effects inside the cell. One of the major things which amino acid leucine does, you can see here a famous paper from UK, activation of mTOR. I don't know, some of you would have had mechanistic target of rapamycin or mTOR, which is the switch on, switch off switch which is present inside each cell. I was staying in a hotel yesterday night, one of the star hotels, and the night before going to sleep, I was trying to switch off the lights. Every time I switched off one switch, something else came on. If I switched that one off, something else came on, and I had to call the reception. Hey, I want to sleep in darkness. Please come and switch off the lights. I mean, very funny request. He came, he pulled the pillow from the bed, and behind that was one switch. He just switched it off, everything got switched off. So mTOR is something like that. It's an anabolic catabolic switch. You switch it on, the cell starts dancing, the ribosome starts multiplying, the protein starts multiplying, DNA multiplies, everything is a party inside the cell. You suppress it, it goes on to protein degradation and autophagy. I put this up simply to impress all of you that I actually understand it, but I don't understand a bit of it. All that it says, I know is when leucine combines with the ribosomes, eventually through a series of steps, it stimulates mTOR towards anabolism. This is something not many amino acids can do, but only leucine is capable of doing it, and that is why you find high leucine content proteins like, for example, whey. You compare whey with meat, even meat has got very little leucine in it. Rice, practically nil, almost zero. So this is the secret why whey happens to be such an excellent cheap protein for our toddlers to take. And yeah, I told you this is what I need to put. There is a product which is now available in a liquid form. Whey is always available in a solid form, in the powder form, but it's very difficult to take. You try putting it in your food, the texture changes, the taste changes, everything changes, nobody will eat it. But in a liquid form, especially flavored, I'm fairly certain children will accept that. There are a lot of myths about fats. In fact, in a recent obesity talk, many of the delegates objected when I said 30% of calorie requirements of a child should come from fat. They said it's going to make the child fat. No, not really. That's honestly not true. As long as the total caloric intake is less than or about what the child requires, 30% of unsaturated fat, of which about 10% is saturated. This is where most Indian diets fail. Very few, I mean, everybody is terrified of butter, everybody is terrified of ghee, everybody is terrified of oil. They all say it's bad, it's bad. It's not. Fat is very essential for cholesterol and DHA, which your brain requires. They are high dense energy source, support synthesis and regulation of several hormones. Look at the average fat intake. This is Anand Nigam from All India Institute. She looked at the fat intake of Indian children in different. You can see here only the very high income group, the fat intake was adequate as per the recommendation. But that's bad news because that was all saturated fat. That was all pizzas and that was all hamburgers and that was all similar foods. As you go down, upper middle class, lower income group, rural group, the fat intake goes down further and further. So as pediatricians, we must encourage children to be given fat in adequate quantities, provided you don't cross their total caloric requirements. Just a few micronutrients, vitamin D. And this is a famous paper which came, Tale of Two Epidemics. You can see here an observation. I just told you a few minutes ago about how you get married and then you start putting on weight. It's just an observational study. It may not prove anything, but it does show that there is an association. You can see here significant increase in vitamin D deficiency, and it is paralleling the obesity increase. As the child starts putting on weight, its vitamin D levels go down. Naturally, it goes down because the fat starts collecting up the vitamin D and it gets dissolved in it. The bioavailable vitamin D in the blood becomes lower and lower. So if you are going to check vitamin D in any obese child, it is likely to be low. Now, there is ethological evidence of vitamin D deficiency and adiposity. You know bears. Bears in the northern Canada and USA hibernate. You know what hibernate means? It means around December, January, February, March, they live inside a cave, eat nothing, drink nothing. They may even get pregnant and have children, but do nothing at all in the form of no intake goes in. For that, over the months of September, October, November, December, they start dramatically accumulating fat. What is the cue that makes them accumulate fat? Vitamin D levels. When the vitamin D levels start going down because of reduced sunlight, you know, in the northern hemisphere, the sunlight, the duration goes down as winter approaches, and as the vitamin D levels fall, the fat accumulation increases. So again, an excellent observational study that there should be a connection between those two. Natural vitamin K, you heard about K2. K2, many people might not be familiar. No, I didn't make that noise. Please don't stare at me. No, that wasn't me at all. That was somebody there. Just about a couple of minutes. Vitamin K we know for more than 70 to 100 years, but vitamin K2 we know only the last few days. It's very, very, very similar to K1, but it has completely different effects compared to vitamin K. This is available in certain fermented foods, which might make you think your yogurt contains it, might make you think your idli contains it. No, our idli or curd use your usual Bulgaricus lactobacillus is my. Are you audible? Oh yeah. So the probiotics which create yogurt don't produce K2. Only 2 products in the entire world, sauerkraut, those who have gone to Germany will know fermented cabbage, and in Japan fermented soy. So you need to take K2 along with whatever food in the form of additional, like there are products which contain vitamin K2. What is the role of vitamin K2? It activates inactive osteocalcin. Now osteocalcin active is required for calcium to enter into the bone. Now if I get a check from somebody, for example, a 5,000 rupee check, I cannot walk into a hotel and give him the check and pay for the food. I obviously have to put it in the bank, convert it into cash, and then pay for it, which is what vitamin D by itself won't be able to do the job. It needs an inactive osteocalcin to complete the job. You can see here a fantastic study in Japan where around 300 to 400 fractures were analyzed over a period of 5 years, and they compared the inactive osteocalcin levels with children who did not have fractures but came for something else. You can see here the ones who had fractures had significantly higher levels of inactive. Just a few words on eye health, a new knowledge which has come within the past 5 to 10 years. There's a close relationship between mobile watching and increased myopia. I'm almost done, just a couple of slides. You can see here the number of hours a child spends watching mobiles, the incidence of myopia increases. Is there any product available? There is a study going on about lutein and zeaxanthin. I'm not spending too much time on that. They are excellent antioxidants. What they do is they have a lot of electrons to spare with a spread. If there is blue light, what does it do to the macula? It hits the oxygen and knocks off the electron. With 1 electron minus, it's like my wife has gone to the US and I'm having a party. I'm uncontrolled. There's no control at all. That's what happens when 1 electron is lost. The oxygen becomes hyperactive, goes about destroying everything else like a bull in a china shop. What does antioxidants do? Provide a paired electron. In fact, my wife has told 2 or 3 of my friends to be the electron and make sure I don't go out of what I should be doing. So summarizing, while there's a lot of emphasis on 0 to 1,000 days of life, very little is said about nutrition beyond 1,000 days. Most people don't talk about it. Carbs are a major neglected area in toddler nutrition because invariably children receive much more carbs than they should, and they should emphasize a lot on lactose. Protein intake in most parts of India are adequate, reasonably good after 2 years. 6 months to 2 years, they are abysmal. They are really very, very bad. An important reason for stunting in India. But surprisingly, after 2, they seem to improve. But predominantly, they are class 2. Whey is an excellent class 1 protein. Fats are inadequately used in India, basically because of the myth, more fat, you're going to become more fat. As long as you maintain your calorie requirements and take 30% of it as fat, it's definitely healthy. There's no need for you to worry about. Several growth promoting micronutrients exist. Only a few I touched upon, and thank you for the patient listening.
Thank you, sir.
Sorry, sir, I didn't touch upon sarcopenia.
I know it is a
honestly,
huge topic. You could only you could do justice in 20 minutes allotted to you, sir. Thank you, sir. Next time we love to hear from you on the same topic.
Thank you, sir.
The next topic is on chronic diarrhea. If yesterday acute diarrhea was bread, butter, jam for the pediatricians of yesterday, chronic diarrhea will be the nightmare for the pediatricians in future. The incidence of...
There is one good silver lining, sir. Diarrhea stopped. Now we survive on constipation. we see hundreds of those cases. We stopped diarrhea but converted the entire problem into constipation.
The decreasing incidence is essentially due to rotavirus vaccination, better hygiene, and high standards of living. The chronic diarrhea is increasing because of lack of exclusive breastfeeding, improper weaning, and changing food habits. And on top of that, travel, increasing travel, junk foods, antibiotic abuse have all contributed to the increase in the diarrhea. Besides that, there is also a group of newer etiology emerging, the chronic congenital diarrheal disorders and the inborn errors of metabolism, which is going to be the etiology in some of the chronic diarrheas at least. To talk this, we have Dr. Balasankar, a popular speaker from Madurai.
இது ஸ்லைட் சேஞ்சரு ஓ ஸ்லைட் சேஞ்சர் தனியாக இருக்கோ Very good morning, one and all. At the outset, I would like to thank the KONGU PEDICON team for giving me this opportunity, Dr. Rajendran, Ismail, Sasikumar, Jayadran and all others for giving me this opportunity. It's very difficult to talk after Dr. Bhaskar Raju, please pardon me. So I'll be talking about a little about chronic diarrhea today. So what is chronic diarrhea? It is simply defined as diarrhea lasting for more than 14 days is chronic diarrhea. But if you see the causes, etiopathogenesis of chronic diarrhea, the pattern of it varies between the developed countries and the developing countries. WHO recognized this clearly and found out that majority of the diarrhea which goes on for more than 14 days is probably of infectious or post-infectious cause in developing countries, and it is something else which causes like malabsorption, congenital defects and all that cause chronic diarrhea in developed countries. So what they did is they coined a terminology called persistent diarrhea in children. So persistent diarrhea is once again it is more than 14 days, but it is of infectious etiology and it is of abrupt onset. On the other hand, chronic diarrhea per se is not infectious and it is mainly due to other causes like malabsorption, congenital causes and all those things. As we all know, this persistent diarrhea is a very common problem in a developing country like India. I will dwell more with persistent diarrhea and touch upon chronic diarrhea to some extent. So what is the epidemiology of persistent diarrhea? A small percent of diarrhea only goes on more than 2 weeks. Maybe 80 to 90, 95% of the children become all right by 1 week to 2 weeks of diarrheal illness. But only a small percentage, maybe 5 to 10, it may extend beyond 2 weeks, and that's called a persistent diarrhea. And persistent diarrhea is more prevalent in younger age children. Younger the child, the chance of an acute diarrhea becoming persistent is more, and almost 90% of the persistent diarrhea occurs in less than 1 year old children. And malnutrition, persistent diarrhea go hand in hand, and a malnourished child has a 20% chance of going in for persistent diarrhea whenever it gets an acute diarrhea. And why this 14 days cutoff? Because they found out it's an arbitrary only actually the 14 days. And whenever the diarrhea lasts for more than 14 days, they have noticed that the mortality is due to diarrhea increases exponentially after that. That's why that 14 days cutoff came. And this prolonged diarrhea, persistent diarrhea is responsible for nearly 1/3 of the death due to any diarrheal illness, secondary to your dehydration, septicemia and all the other complications of diarrhea. Okay, what is the pathophysiology of this persistent diarrhea? There are 3 factors which play a role here. First is the infection. It's a something persistent infection in the gut is responsible. That's the hypothesis that got. Actually, etiopathosis, exact etiopathosis is not known. Only the hypotheses are being told, and these are the hypotheses which have been proposed. One is persistent infection. Remember, Shigella is an infection. If it is not treated properly, can lead on to persistence of infection beyond 2 weeks of age. Nearly 1/5 of the case of Shigella dysentery can persist more than 2 weeks. And coming next to it is enteropathogenic and enteroadhesive E. coli, then Salmonella, Campylobacter, Giardia, of course, amoeba also, and some special organisms like Cryptosporidium which causes persistent diarrhea or chronic diarrhea in immunosuppressed, as well as some systemic infections like your urinary tract infection, pneumonia, ASOM can also lead on to persistence of diarrhea. Then coming to the host factors, malnutrition plays a major role. We know that malnutrition, micronutrient deficiency per se leads on to suppression of immunity, especially the cell-mediated immunity. So the clearance of the organism from the gut is going to be delayed in these conditions. And we all know that the zinc and vitamin D are essential for maintenance of the epithelial layer of the intestine. If they are deficient, it can lead on to faulty repair of the intestine after acute diarrhea and lead on to persistence. Then infants, the gut is immature. So they do not replicate, the cells do not replicate well, and they are more permeable for the antigens and pathogens also. In that way, infants are more prone to develop, get persistent diarrhea. And no breastfeeding and early cow's milk feeding, less than 1 year, it is not advised at all. So if you feed them with cow's milk, they can lead on to sensitization and chronic diarrhea. And unnecessary use of antibiotics during acute diarrhea. Knowing well that acute watery diarrhea does not need antibiotic. So many of us prescribe antibiotics a lot in acute diarrhea. And that leads on to destruction of the good bacteria in the gut and proliferation of bad pathogens, including the fungi in the gut. And that can lead on to persistence of diarrhea. And of course, overcrowding, poor sanitation, and all those things can lead on to repeated infection with the same organism or repeat with some other organisms repeatedly in the gut, and that can lead on to injury to the gut and persistence of diarrhea. So it is a vicious cycle. We all know that diarrhea per se leads on to decreased nutritional status. Upon that, there is anorexia and faulty feeding. Our mothers restrict all the solids whenever the child gets diarrhea. So many food fads are there, not to give so many things. So all this leads on to worsening of the nutrition status. This leads on to poor reparative capacity of the intestine. So it leads on to persistent intestinal damage and villous atrophy. That leads on to deficiency of these digestive enzymes like lactase and other disaccharidases. That leads on to impairment of digestion and absorption. Once again, it is worsening the diarrheal status. So this is going to go on as a cycle. And unless you correct the nutritional status, that the diarrhea is not going to improve. So how do we evaluate? Stool examination, though it is not stressed much, please remember, even though we don't say that infection is not a major cause for persistence of diarrhea, remember, we have to identify whether there is a possibility of persistence and do that. So more than 10 parcels per hyperfil, persons of RBCs in the stool, and you have to look for trophozoites and cysts of Giardia lamblia and Enteromoeba histolytica. These are the two organisms that can lead on to persistent diarrhea. And only one stool examination may not be sufficient because the shedding is going to be very irregular and irregular. So you got to do for 3 days before saying that it is negative. And there are so many concentration techniques in the tool to isolate Giardia also. And you have to look for fungal hyphae where Candida may be one of the causes. And please remember, even though I mentioned our stool, enzyme immunoassay, it's a serological test has come nowadays, which can diagnose Giardia, EH and Cryptosporidium easily. And doing stool culture, it's one of the very technically difficult investigation actually. Don't do it in acute diarrhea, but in persistent diarrhea you can try. But remember, it has to be plated immediately after collecting, number one. Number two, see to that the lab is qualified enough to find out the genus as well as the species. Not saying just E. coli is enough. E. coli what type, they have to say. So lab should also be good. And remember, these special organisms which can cause persistent or chronic diarrhea require some special media also. And you have to screen for systemic infection of form of total count, differential count, urine culture, blood culture, and all those things. Then, what is the management? You need not admit majority of the children if they are reasonably good and they are nourished and taking feeds and all, they are fine otherwise. But you have to admit if there is signs of dehydration or child is having severe acute malnutrition, and if they have got systemic infection, probably to give parenteral antibiotics, we have to admit. And less than 6 months old non-breastfed is a very tricky area where you cannot give the diet which you advise for older children. So they will be needing some special diet like some extensively hydrolyzed formula or elemental amino acid formulas, and they may go in for so many complications. So better you admit any child who is less than 6 months but it is not breastfed. So dietary management is the key cornerstone in the management of persistent diarrhea. As I already told, nutritional status has to be improved first, and we should remember that if the child is breastfed, continue with the breastfeeding. That's point number 1. Number 2, see to that child is getting at least 6 or 7 feeds per day and gets at least 100 calories per kg per day, so that it will recover from the illness. Number 2. Number 3, you have to give micronutrient supplementation. Number 4, if the child is not able to take orally, then you have to put an NG tube and start feeding them parental, give them enteral feeds for 1 or 2 days, and once the child recovers, you can start them on oral feeds. So what's the mainstay in the management? So we all know that lactase is the enzyme which is first, last, and lactose intolerance is the first thing which we are bothered about, which is going to cause a problem in persistent diarrhea. So what we do is reduce lactose diet is the diet A that is advised, where we need not eliminate the milk totally and reduce it to less than 50 ml per kg per day. And we have to add milk along with locally available cereals and pulses and make it as a kanji or so and feed. And this is far better than a soy-based formula. And these are some of the things: rice, milk gruel, and rava payasam, something like that. These are all some preparations which you can use. With the type A diet, at least 60 to 70% of them become all right. And if it is not responding, then you go for a type B diet, where you not only make it lactose free, that is total restriction of milk, also the starch is reduced in the diet. That is, the carbohydrate is provided in the form of mix of cereals as well as glucose. And protein is given, because milk is taken away, protein is given in the form of egg or chicken, egg white of course. Okay, this is one of the diets which can be used in diet B. And with diet B, at least 80% of them will be recovering, and only a very small percentage will be requiring what is called a type C diet, and that contains only glucose, no complex carbohydrates, only glucose, and the protein sources as egg white or chicken and oil of course. And this is the one. And with this dietary modification, adequate feeding and nutritional supplementation which has to be given, 90 to 90% of them will recover. So this is the supplements we give. We know the importance of zinc, it has to be given. All these are to be given for at least 2 weeks or 14 days. And vitamin A is given as 1 dose, vitamin K 1 dose. And of course, in a malnourished child, they need also magnesium and potassium supplementation. Potassium 5 to 6 milliequivalent per kg per day, and magnesium sulfate also. And to add iron when they stop diarrhea and start showing some improvement in dietary intake. Maybe after 3 or 4 days, you can add iron to them. With this dietary modification, they usually do well. And how we assess the success of dietary intervention? It should be less than 2 liquid stools for at least 2 consecutive days, and they should gain weight for 3 consecutive days, and child should be taking adequate diet. Then your diet modification is successful. If it is not happening, many stools are still there, child is passing continuously watery stools, failure to gain weight for even after 7 days, and there is return of sign of dehydration, then your diet modification is not working, and you may have to go to the next diet and all. Okay, right. So wait for 7 days before deciding. So give a course. Unless the child condition worsens drastically, you wait for 7 days and decide whether the child is improving or not, and act accordingly. If everything goes on fine, after 10 days or so, if diarrhea stops and starts gaining weight, you can slowly start introducing milk, small quantities. And after that, if the child is able to tolerate, you can add all the other diet what the child was taking earlier and make a normal diet, and raise the caloric intake to 150 calories per kg per day after 1 week or 10 days for catch up of the growth. And this is the one which is coming up recently. Unripe green valakai, avicha valakai or valakai, some companies have come with powders also. So that is supposed to contain amylase resistant starch. It is not getting digested in the upper intestine. The starch reaches as such into the colon, where it is broken down by your intestinal bacteria into short chain fatty acids, and they not nourish the good bacteria, that is your probiotics, that it nourishes them, and it repairs the mucosa also, it nourishes the colonocytes also, and it also improves absorption of short chain fatty acids also occurs along with water. So this is supposed to be very good, of very good use in chronic diarrhea. Do the antibiotics have any role in management of chronic diarrhea? Only a limited role, almost nil I can say. But when there is systemic infection, severe acute malnutrition, yes, definitely they will need parenteral antibiotics. What about the other condition? Presence of obvious blood in the stool, and you are sure that it is dysentery only, and specific pathogen is identified. For example, Campylobacter jejuni or Shigella, something is identified. Two drugs are suggested in Nelson actually. Number one is azithromycin, which is very effective against E. coli, Shigella, your Salmonella and all. It covers everything. So you can try that for 3 days. And nitazoxanide is another that has been suggested in Nelson. Once again, it is effective against Giardia, Cryptosporidium as well as amoebiasis. So you can keep this in mind, and you can use in select cases when you are sure about the diagnosis of the etiology. Probiotics, even though there are so much of hype, it is not being advised. And resveratrol as an anti-secretory agent is also of not much of use. Loperamide, you use it when only there is a gastrocolic reflux in the child. Then coming to the chronic diarrhea per se. So what are the causes of chronic diarrhea? Long list. Actually, I only put a very few in this one. It's a very long list where infection, post-infection, I already talked about that. Then cow's milk protein allergy, immune deficiency, celiac disease, tuberculosis, toddler's diarrhea, inflammatory bowel disease, cholestasis, pancreatic cystic fibrosis, and intractable diarrhea of infancy. It's one of the important causes where even in newborn period, starting from the newborn period, you can have. There are so many kind of malabsorption syndromes like glucose galactose malabsorption, microvillus inclusion disease, antibody against this enterocytes. So many things are there in this intractable diarrhea of infancy. So we will see a little about one or two causes, important causes. Cow's milk protein allergy is one of the important causes for persistent diarrhea, chronic diarrhea in young children, infants especially, less than 2 years of age. Almost 13% of the chronic diarrhea is caused by this problem, and the prevalence is around said to be around 1.5 to 3% in our children. And remember, it usually resolves by 3 to 5 days. So don't diagnose cow's milk protein allergy after 5 years. It's very rare after that. And it occurs after introduction of cow's milk. Not only cows, buffalo milk, goat milk, even maybe donkey milk also probably. So it causes allergy, and we all know that it is a beta lactoglobulin which is responsible for that. And we are not bothered about that IG E-mediated, that is an acute reaction. We are bothered about only this delayed T-cell mediated reaction only. Acute reaction namakku diarrhea la varaporadilla. So T-cell mediated only is going to cause diarrhea, and you know that we are aware that it's causing only bloody stools. Please remember, even though mucus and bloody stool is the commonest one, small bowel type of diarrhea can also occur. It can present as watery diarrhea also. If 40% persons with blood in stools, 30% of them present with only watery stools, and mixed type can also occur. Apart from this diarrhea, they can also have vomiting, GE reflux like symptoms, and dysphagia, and sometimes hematemesis can also occur. And anemia, hypoproteinemia, and eosinophilia may be associated. How do we make a diagnosis? By doing a sigmoidoscopy where you get aphthous ulcers and nodular lymphoid hyperplasia, and if you take a biopsy, you will find lot of eosinophils in the gut. Okay, so then strict elimination of the cow's milk is the answer, and soy milk formula is usually not advised in less than 6 months. Maybe you try after 6 months, and extensively hydrolyzed formula or elemental amino acid formula may be the answer for up to 6 months. After that, you can give your cereals and all those things. Okay, then coming to immune deficiency, selective IgA deficiency, severe combined immune deficiency, common variable and CGD can cause also, AIDS can also cause chronic diarrhea. And common organisms which are usually involved in immune deficiency are Giardia, Cryptosporidium, CMV in AIDS children and immune deficient children, and bacterial overgrowth into the gut. These are the causes. And how to make a diagnosis? You can do immunoglobulin assay, you can do flow cytometry and find out percentage of CD4, CD8 and all these things, and a test for HIV. Okay, then coming to the next cause, celiac disease. This is very common in North India, may not be in our setup. Permanent sensitivity to gluten, so they can never take gluten in their life. They cannot take godumai at any part of their life. That's the thing. and it's common. Genetic predisposition and Down syndrome and type 1 diabetes may be associated with increased incidence of this disease, and it causes typically small bowel diarrhea, large volume bulky stools. That's what it occurs. It causes growth failure and anemia. 1 minute or 2 minutes? 2 minutes. On introduction of it occurs, and the diagnosis by anti-TG2 Ig antibody and anti-endomysial antibody. And as I told, there is a great genetic predisposition, and this HLA types are associated. You can do HLA typing also to make a diagnosis. Endoscopy and biopsy. Biopsy shows total villous atrophy. Okay, right. Then coming to inflammatory bowel disease, it's not uncommon nowadays. But lifestyle mara in the disease area vandukittu. So 25% of this IBD occurs in childhood. Onset occurs in childhood. Average age of presentation is around 10 to 11. Not in very young age actually. 30% have family history. Please remember that. We know ulcerative colitis causes diarrhea and blood in the stool. Crohn's disease presents with mainly pain abdomen, diarrhea, growth failure, and other systemic manifestations can also occur like arthralgia, arthritis, uveitis, erythema nodosum, perianal fistula, and all those things. And you diagnose by looking for inflammatory markers, stool calprotectin, lactoferrin in the stool, and by doing endoscopy. Okay, right. And management is, I leave it to you, this is a very big area. And abdominal tuberculosis, if I don't say tuberculosis is a cause of diarrhea, I am not an Indian. So I include that abdominal tuberculosis can also cause chronic diarrhea. And toddler's diarrhea is the one which is peculiarly where the child is eating lot of juices, especially apple juice and all, which contain lot of sorbitol, and child is being bombarded with only carbohydrates, lot of carbohydrates. They can pass 4 to 5 or 6 stools per day. And it starts by about 6 months of age and can last up to 3 to 4 years. And slowly it subsides after 4 years. And if you restrict this fluid, especially fruit juice, rich in sorbitol, that is apple juice and carbohydrates, and increase the fat and fibers, it will improve. So, I think I will stop with this slide. Small thing, you say approach is little tough. Chronic diarrhea, chronic diarrhea and the mala vanduchina, I will just refer it to Dr. Bhaskar Raju and keep quiet. Because it is, evaluation is very, very difficult. Investigations are quite costly, and they are not available in tier 2 cities. Tier 3, Madra tier 3 solitalume, Smarana labs are. So it's very difficult to evaluate. But some points, you can make out whether it's small bowel or large bowel diarrhea. Where small bowel diarrhea is large quantity, pale, foul smelling, oily stool, and no blood will be there. And they will have periumbilical pain, rough or vague pain, and which is not relieved by defecation. But large bowel diarrhea, small quantity and not foul smelling, and usually blood will be there, and they will have lower abdominal pain typically, and tenesmus will be there, and the pain will be relieved on defecation. Of course, then there are 2 other types of diarrhea. By asking the history, you can make out asthmatic or secretory. Asthmatic, once again, it's a large volume explosive stool, perianal excoriation, all those things, you all know that. And remember that on starvation it stops. And in secretory diarrhea, it's watery, and there will be severe features of dehydration will be there obviously, and they do not stop on starvation. But unfortunately, majority of the diarrheas are mix of these 2. So it is very difficult to make out what is what. Okay, by this history, thorough history and clinical examination, you will be able to make out what could be the possible cause of that. You have to measure all these things. You have to look for edema. Edema is very obvious in protein losing enteropathy. Remember that, where this lymphangiectasis malformation of the intestine and all, where edema will be very severe, as well as in cow's milk protein allergy. Okay, so investigations are very costly, and they are not available in that easily. So these are some of the investigations which you can use. Osmotic gap in the stool is very, very important to differentiate between whether it is osmotic and secretory. If it is less than 50 millimoles, it is secretory diarrhea. If it is more than 100, it is osmotic diarrhea. Fat estimation stool, protein estimation, protein losing, we estimate fecal alpha fetoprotein and find out whether it is excreted. So these are the investigations you will be doing, and the cystic fibrosis for and all. And management, it's very difficult actually to manage chronic diarrhea. Diet modification, it may help, sometimes it may not help, and you may have to resort to total parenteral nutrition. Sometimes for congenital diarrhea, something like that, which are very severe, that protracted diarrhea of infancy and all, and you may have to go for this intestinal transplantation. Okay, so In our setup, persistent diarrhea is mainly because of infection and post-infectious causes. Remember that. And dietary modification is the only one which may be needed in majority of the children to get controlled. And breastfeeding, proper weaning and avoiding antibiotics during acute diarrhea and good water supply is the one which is essential for prevention of chronic diarrhea. And chronic diarrhea per se needs some extensive investigation and management by a gastroenterologist. Thank you very much for your patient hearing. Sorry, I had to rush the terminal slides. I did not have time. Thank you very much. If there are any queries, my guru will answer. Thank you.
Thank you so much, sir.
Mike Leah.
Thank you for outlining the dietary management, which is not often taught in the medical schools nowadays. So if there are one or two questions, either on the WhatsApp or somebody in the audience, it can be answered.
Yes, ma'am. Yeah, paneer contains a lot of casein. That's the main problem. It does contain whey, no doubt about that. Casein is a double-edged sword. It's excellent for growth, but it's also highly insulinogenic. It has what is called the glycomacropeptide, which is full of branch chain amino acids, which push sugar, everything into the cell, which is why when it comes to obesity, we are a little careful about casein. So paneer is definitely a good protein. Nobody denies that, but it's only 20% whey. 80% it is casein. So we cannot depend on that to provide whey to the child if our intention is to provide whey to the child.
Any natural source of vitamin K2? You showed some cabbage and said fermented cabbage.
Vitamin K2 can only be synthesized by organisms. And animal cells can synthesize a type of vitamin K2, which is called MK4. But the common vitamin K2 is MK7, which is only produced by organisms, mostly marine organisms. The ones which we are familiar with is Bacillus subtilis, which is used in the production of those two products which I told you. Sauerkraut, which is fermented cabbage, and fermented soy, which is a famous Japanese dish called natto. Our usual fermented products in India, they all use Saccharomyces or Lactobacillus bulgaricus, neither of which produce K2, which is why K2 to be given as either a supplement or something becomes vital and important in children.
Thank you.
Thank you, Vivi.
We thank the audience for their questions.
Question from Dr. Virdagre will be the last one.
Okay, sir.
Last question, yeah. But I didn't touch upon sarcopenic obesity because basically it's an adult problem. Children, we don't see it that often. But yes, sarcopenic obesity does have a future probable cancer effect. There is. So, but that's fortunately for us is not a major problem in pediatrics.
Sir.
Thank you, sir.
Sir, animal protein inclusion of meat and egg is more of a Western thought. More of a Western thought. Our plant protein is the best. Another thing, supplementation may be needed for a few things, B12, zinc or something like that. But general supplementation is a reductionism. It's not a holism. It's a reductionism. You choose out something which can work only in a combination.
Thank you, sir. You always appreciate from seniors your inputs.
Sir, Bala or my Guruji can take up this, sir, because the green banana which you are mentioning, Bala, is nowhere available. Is that the hill plantain probably will be of value? Okay. And one more thing is, probiotic, you said no role. What about the probiotics which are available, you know, like naturally? Like
yes, sir.
yogurt,
Sir, it is all
buttermilk?
individuals, they have their own experience, and majority of the others, they agree that it is useful. But Somehow or other, it is not coming in standard books and references. They say that enough evidences are not available, and so it is not advised. That's what it is written of. Lastly, this is the word they write. There is no enough evidences to suggest the use of probiotics in persistent diarrhea. That's the word they give. Maybe individually, yes, it may work. Individually, it may work.
We wind up the session with this, and I hand over the mic to the organizers for the honors.
Thank you so much, sir. On behalf of the organizing committee, we extend our heartfelt thanks for your time, effort, and generosity in sharing your knowledge. We request Ramesh, sir, to present tokens of appreciation to Dr. Bhaskar Raju and Dr. Balashankar. We request Dr. Bhaskar Raju to present a token of appreciation to our chairperson, Dr. Ramesh. Thank you all. We request our speakers to kindly note that a souvenir with your photograph from the session can be collected from the display just outside the SIRUVANI hall, which can be found to the right as you exit the hall. Introducing the next session, it is an honor to invite the chairperson, Dr. Neminathan, our senior pediatrician and infectious disease specialist with over 30 years of experience heading pediatrics at Coimbatore Child Trust Hospital. We invite you onto the stage, sir.
Thank you. It's my pleasant duty to invite Dr. Tirumurugan to speak on a very important topic of the day about dengue vaccines. Friends, I'm sure you will all agree with me. Dengue is a very, very breadwinner for many of us, and I'm sure the younger crowd that's there will agree with me. Nearly around 5% of the global population gets dengue annually. That's 5%. That's the magnitude of the disease. And we've got 4 serotypes. We need to have a vaccine that gives equal protection, equal efficacy against these 4 strains. And previously, some of the vaccines that came to market couldn't do that justice. They were withdrawn back. Now we've got probably a couple of vaccines in the pipeline. My friend, Dr. Thiru, can I invite Dr. Tirumurugan to the stage?
As sir is currently held up in a meeting, we will be proceeding with the next speech.
Yeah.
First, we have Dr. Senthil Kumar sir, Professor of Pediatrics at Coimbatore Medical College, who has just this year been honored with the Best Doctor Award by the Government of Tamil Nadu to speak on bugs and drugs in pediatric respiratory practice. We invite you onto the stage, sir.
Yeah, Senthil is my close friend. He is highly knowledgeable and also very, very gem of a person. He has his special interests in community pediatrics, and now he is at present in CMC, Coimbatore Medical College as department head. I invite Senthil to talk on this very relevant topic about the bugs and the drugs for respiratory illnesses. Floor is to you.
Thank you, sir. Thank you for a warm introduction. Very good afternoon to one and all. At the outset, my sincere thanks to the IAP-TNSC for the opportunity given. This topic, the common bugs and drugs for pediatric respiratory tract infection in office practice. The most common cases we pediatricians come across in our day-to-day office practice is respiratory tract infection. Yes, we know viral infection is the predominant cause for the majority of the respiratory tract infection. But however, bacterial infection also constitutes about 4 to 14% of the overall respiratory tract infection in children. But when we see the overall antibiotic prescription rate in India for respiratory tract infection in pediatric OPD, it is almost 55%. It is almost 45% in government hospitals and 57% in private clinics. This high antibiotic prescription rate is mostly due to difficulty in differentiating viral from bacterial infection due to overlapping of the symptoms between these two etiology. So this presentation is mainly to highlight the how to differentiate bacterial from viral etiology. Among the bacterial etiology, what are the common bugs responsible for the majority of the respiratory tract infection, and what are the drugs effective against those bugs, and what is the dosage and duration of treatment, so that by the prompt diagnosis of the bacterial respiratory tract infection, definitely there is a judicious and appropriate use of antimicrobials. Definitely we can reduce the antimicrobial resistance. So as a pediatrician, what are the common respiratory tract infection we come across in our day-to-day office practice? Yes, it's pharyngitis, rhinosinusitis, acute otitis media, croup, and community-acquired pneumonia. Yes, in pharyngitis, actually the viral infection predominates, but however the bacterial pharyngitis constitute about 14% of the total pharyngitis cases in India. So what are the clinical clues to differentiate viral pharyngitis from bacterial pharyngitis? Usually a child with viral pharyngitis presents with cough, coryza, conjunctivitis, involvement of the other mucosa like diarrhea, hoarseness of voice, or oral ulcers. Suppose most of the time the oral ulcers involving the anterior part of the oral cavity most likely to be of herpes simplex, whereas involving the posterior oropharynx it's most likely to be of herpes angina. Whereas a child with bacterial pharyngitis, usually a school-going child in the age group of 5 to 15 years, presents with high-grade fever, headache, abdominal pain, palatal petechiae, pharyngotonsillar exudates or anterior cervical adenitis. So these are some of the features which gives us a clue we are dealing with bacterial pharyngitis rather than viral pharyngitis. So what are the bugs responsible for this bacterial pharyngitis? Yes, it is Streptococcus pyogenes, Streptococcus pyogenes. All other things are quite rare to consider in our office practice. So when to initiate antibiotics for a child with pharyngitis? Yes, we go along with this McKissick modified center criteria. Actually consists of 5 parameters. One is the age of the child, usually between 3 and 14 years of age, and tonsillar swelling or presence of tonsillar exudates, presence of anterior cervical nodes, high-grade fever temperature of more than 100 degree Fahrenheit or absence of cough. Each parameter carries a score of 1. If the total score is less than 2, it's most likely to be of viral pharyngitis. There is no need for antibiotics. If the score is 4 or above, yes, it is most likely to be of bacterial pharyngitis, where we start the antibiotics empirically. Whereas, if the score is between 2 and 3, what the guideline says is we are supposed to do the rapid antigen reduction test. If the test is positive, yes, we have to go for antibiotics. But if the test is negative, yes, we are supposed to do a throat swab culture, and if the culture is positive, we have to start antibiotics. This is what the guideline says. But in ground reality, it may not be practically feasible in peripheries, yes, because of the non-availability of these tests easily. At times, you can easily able to do a genomic sequencing, but these kind of tests, which hardly cost 250 to 400 rupees, may not be easily available. In such a situation, yes, we can consider antibiotic. We can observe the child for 24 to 48 hours with the symptomatic treatment. If the child is improving, yes, fine, well and good. Suppose if the child's condition deteriorates, or if the child has already, any of the family members having acute traumatic fever and on prophylaxis, in such a situation, yes, we can go for antibiotics. Otherwise, we can go for wait and watch policy. So what is the drug? The drug of choice is, yes, it is amoxicillin. It is given in a standard dose, that is 50 milligram per kg to a maximum of 1 gram. And it can be given in a OD dose for a total duration of about 10 days. So what are the other alternate drugs? Yes, cefalexin, cefadroxil, or clindamycin, some of the drugs which are effective against those Streptococcus pyogenes, but however, amoxicillin is the drug of choice, and we can it holds the flag. And it has to be noted that if we start the antibiotics before 9 days of onset of illness, definitely we can prevent the occurrence of rheumatic fever. At the same time, we can't prevent the occurrence of post-streptococcal glomerular nephritis. And coming to acute rhinosinusitis, almost in India, children used to have an average of about 6 to 8 episodes of cold per year. Of those, almost 5 to 9% of the viral infection can predispose to secondary bacterial infection, having acute bacterial rhinosinusitis. So when to suspect it's bacterial rhinosinusitis? So presence of persistent symptoms severe symptoms or worsening symptoms. These are the features where we have to consider bacterial rhinosinusitis. Persistent symptoms, that is the Chinese child having nasal discharge or daytime cough lasting for more than 10 days without improvement, or the child presents with a high-grade fever, say for temperature more than 1 or 2 degree Fahrenheit, or purulent nasal discharge lasting for more than 3 to 4 days, or the child may have initially present with a low-grade fever, nasal discharge, daytime cough due to some viral infection, and again the child may have secondary bacterial infection with return of fever, nasal discharge and daytime cough, and this is known as double sickening or biphasic illness. So these are the situations where you have to consider bacterial rhinosinusitis rather than viral. So what are the bugs responsible for this bacterial rhinosinusitis? Yes, after the introduction of this pneumococcal vaccine, the non-typable H influenza is the leading cause for the bacterial rhinosinusitis, almost constituting about 50% of the total sinusitis cases, followed by the pneumococcus and moraxella. And what's the drug we want to choose? Whether we have to go with standard dose amox or standard dose amoxiclav or high dose amox or high dose amoxiclav, because many things are available. But the drug of choice is standard dose amoxicillin with clavulanic acid